Good morning, and I would like to welcome everyone who is present in the Chamber and those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would also add that for those of us in the Council Chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the Council Chamber through the rear doors, through reception, and assemble in the car park at the front of the building and await further instruction. I would also request all members to place their phones on silent and to ensure everyone has the opportunity to ask a question, to ask a maximum of 2 questions per item, and to keep them succinct and concise. As the meeting is being streamed in the usual way, I would like to remind you all that your comments will remain accessible online. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies for absence from Councillor Richard Cleaver, Sarah Parkin, and from the newly appointed representative for the City of Lincoln Council, Councillor Emily Wood. Replacement members today, we should have Councillor Marion Overton, who's going to be the replacement member for Councillor Richard Cleaver, and Councillor Callum Watt for Councillor Emily Wood. We've also had apologies for absence from Councillor Sue Woolley, Community Engagement, Registration and Coroners. Thank you, Chairman.
Thank you, Trina. I'll now move on to agenda item 2, declarations of members' interest. Do members have any interest to declare at this point? No. If any should crop up throughout the meeting, then please indicate and we'll make sure we get them registered. Now I'd like to move on to agenda item 3, the minutes from the 19th of April. You'll find these on pages 3 to 7 of the agenda pack, and I propose on taking these en bloc. Do I have a proposer for these? Thank you, Councillor Linda Wootton. Seconded, Councillor Ray Wootton. All those in favour, please show. Thank you. That's confirmed. Have we got abstentions? Thank you. Okay, thank you. That's carried. We'll move on now to agenda item 4, the Chairman's announcements. My Chairman's announcements were circulated as part of the agenda, and supplementary announcements were circulated on the 16th of May. Are there any questions on the announcements? Councillor Smith, please.
Thank you. It's more of a comment, Chairman, with your indulgence. In your supplementary announcements, you've alluded to funding the government's made available around telephony and internet provision. Chairman, I have to say, from the outside looking in, that money could be, shall I say, better spent on other things, because yes, while some telephone services I accept do need an upgrade, I think patients would much rather that sum of money is spent elsewhere, because it's not actually, in most cases, the actual issue of getting to speak to somebody in terms of doing it. It's actually getting to see somebody that's the problem, and that's where the money should be best spent. But I think I should just put that on record, Chairman, because I'm sure we're all of a similar view, but I thought it needed to be said.
Yeah, thank you, Councillor Smith, and it's something I'm sure we can pick up when we have our GP update anyway. So, Councillor Allen.
Thank you, Chairman. I'd just like to concur with the comments made by Councillor Smith. It does seem that the announcements are more to do with money being allocated rather than actually solving problems.
Thank you. Your comments are noted. Councillor Ray Wootton.
Yeah, thank you, Chairman. I'd also like to comment on that. It's not not the technology, it's the people behind the technology. If you haven't got enough staff there, it's putting so many extra technology in place. Because nobody to answer the phone, it's pointless. Thank you.
Thank you. If there's no other comments, do I have a proposal that we note my announcements, please? Councillor Linda Wootton, and seconded by Councillor Smith. All those in favour, please show. Thank you. That's supported unanimously. I'll now move on to agenda item 5, Paediatric Services at Pilgrim Hospital, Boston. This item was circulated as part of the agenda pack on pages 11 to 21, and I would like to welcome our presenters from United Lincolnshire's Hospitals NHS Trust via Teams. We have Andrew Morgan, Chief Executive, Simon Hallion, Managing Director of Family Health, Anna Richards, Associate Director of Communications, and we've got a PowerPoint presentation too, I believe, so I'll hand over to you for the presentation for 10 to 15 minutes. We'll take the papers as read and just any sort of further update. Thank you.
Okay, thank you, Chair. If it's okay if I kick this off. So morning to you, Chair, morning to everyone. Hope you're all safe and well. I'll do a quick intro. I'll then hand over to Simon Hallion, the Managing Director for our Family Health Division. I have also got Suganthi Joachim here, our Clinical Director for the Family Health Division as well. So I think between them, they'll be able to pick up the specifics of the service. But if I just do an intro from a trust perspective, and I imagine for many of you in the council chamber today, this is not a new topic that you've come to cold. I think we've had many updates at previous scrutiny committees following the changes that were made back in 2018, in fact, so predates me and my time at ULHT. But since those changes were made in 2018, the service has evolved, it has changed, it has improved, and it's continuing to develop right up until today. And we've not done that evolution, we've not done that development in isolation. We've had very active engagement with families, with community representatives, and with our own colleagues at Pilgrim Hospital. And having now reached a position of a much more stable, high quality and sustainable service, we now want to consult the public about making the current model of service a permanent service model. So our intention, as set out in these papers, is to take the consultation document to the ULHT board in public on the 6th of June, and then commence from the 7th of June a 12-week public consultation that will take us up through until the end of August. And the outcome of that consultation would then go back to the ULHT board, will reflect on the comments made, and then make a decision. So I think today's paper is mainly about an update as to where we've got. You haven't got the actual consultation document with you, but as you said, Chair, you have got a presentation, and I'll hand over now, I think, to Simon Hallion, our Managing Director for our Family Health Division, to give you the overview of where we've been, where we are now, and how we've got where we are now. So I'll stop at that point and hand over to Simon. Thank you very much.
Thank you, Andrew. Thank you, councillors. I was going to make one of the same points that Andrew made, because I've been to the Health Scrutiny Committee several times to have conversations around just this matter, and we did agree pre-COVID to go out to public consultation under your direction for a 12-week period. So COVID unfortunately got in the way, but this is us returning to agree with you how we take that action that you directed previously. We haven't gone into huge detail about what the model is within the paper, because clearly that's within the public consultation. But if I talk you through the presentation that you've got, and we deal with any questions you've got on it, then hopefully, as I say, we'll come back to a meeting in, I think it is June, is it, Anna, that we're coming back? And we will go through the full detail and give you stats and other things at that point. So those who weren't aware of it, there were problems in 2018, a culmination of several years of developing problems in the children's service here at Pilgrim Hospital. And it ended up with a position where there wasn't a sustainable service, so we couldn't get substantive consultants into place. There were questions about the training of junior doctors, and eventually the HEAM team withdrew the training status for Pilgrim Hospital whilst we sorted out staffing. That culminated in a position where the organisation had to decide how it was going to maintain a paediatric service at Pilgrim in that context, and the decision was taken to move to a 12-hour length of stay paediatric assessment unit. So a facility that any child could go to, if they could be treated and assessed in 12 hours, that would happen on the hospital side. But it was reasonably strict in its initial descriptor that after 12 hours you would need to move to another hospital to continue your care. So that was put in place. Staffing was secured using locums and non-training grade doctors to support that going forward. And the system was supported as well by the procurement of a private ambulance service who would transfer the children at 12 hours to other hospital sites, predominantly Lincoln. In the spring of 2019, or by the spring of 2019, which was a few months after we'd introduced that model, it became apparent that it didn't in practice work well for children and young people served by Pilgrim, and a number of tweaks were made to it. The first one was that the private ambulance service couldn't transfer sicker children. So we were having to keep sicker children on the hospital site whilst moving some of the less unwell off the hospital site. And we also had a position where, understandably, families who'd been through the service once, moved to Lincoln and found that they weren't in Lincoln for more than a couple of hours, were expressing concern about suggestions they move to Lincoln again. So we started to have families who were declining to follow the model. All of that led to us, probably wrong language, but tweaking the model as we moved along. So changing what we were allowing the clinical teams at Pilgrim to do to try and accommodate these nuances that came through. In June of 2019, the CQC came in and assessed us against the 12-hour model and said that we weren't working to it. So part of the criticism we received in 2019 from the CQC was one that we weren't following our own processes and we were doing this sort of development of a model on the hospital side. What happened from then was we started to be much more active in talking about what did the hospital need. We were talking to SOS Pilgrim. We came to talk to yourselves on more than one occasion. We participated in the Big Healthy conversation for Lincolnshire and came to the Boston community to talk about what we were doing. And we basically moved to a position initially where we said that paediatric assessment unit length of stay would be 24 hours. But we at that point said there was also an opportunity for the clinicians to keep a child for a further 24 hours for observation if that would be in the interest of the child and their family. So the model moved to one where we gave much more freedom to the clinicians, and actually we found that we were able to deal with most of the children on that hospital side within that 48-hour period, and the bulk of them are still being seen within 24 hours and discharged. We did that by the whole model at the 12-hour stage was about putting consultants on the hospital site till 10 o'clock at night, and those consultants leading a senior review and senior decision making on every child as quickly as possible after they came in. So that element worked well. The rapid assessment, giving them the freedom to keep children and young people for up to 48 hours meant that far and away the bulk of children and young people then stayed at Pilgrim. And that gave us a stable position that families were happy with, staff were happy with, and we were able to start recruiting staff into a described model that was working. So we then found that we were getting doctors into posts. We eventually got the trainees back to the hospital site at Tier 1. But we also still kept working on that definition of who could stay on the hospital site. And when we get into the full consultation documentation, that will tell you what we've done, which children stay there, and basically that almost every child who presents at Pilgrim now stays at Pilgrim for the entirety of their care, be that a 7-day length of stay or a 9-hour length of stay. So we've moved to that position. We have confirmed that with our clinicians. We've worked that now probably for 2.5 years, this sort of hybrid model of a focus at the front end on rapid assessment and treatment, and then the ability to manage children through to the end of their care, but with a plan that's been developed on their first presentation. And I've managed to get to full establishment for consultant numbers. And those of you who are around remember, I think we had 3 out of 8 when we started this process substantively. We've now got 7 substantive. The 8th one is a NHS locum consultant who is applying for the job as a substantive job with us. We've managed, as I say, to get the Tier 1 trainees back in from HEAM, and we're just about to start conversation with them about Tier 2 trainees. And we have managed to attract predominantly overseas doctors, but into a stable middle grade tier. And we'll talk a little bit about some of the pressures in that when we come to full consultation. But it's basically a stable service at Pilgrim, which wasn't where we were in 2018. As Andrew said, in getting to this situation, we talked to SOS Pilgrim, we came to yourselves, went to the Healthy Conversation, and we've had a lot of input to the Lincolnshire system, Children and Young People's Transformation Board that we have membership of. There has been a fair bit of work already on patient feedback, so family experience of the model. It's a really positive. We've had no active complaints about the service in the period we've actually stabilised it and run it in this extended model, and patient feedback has been very positive about it. So we're feeling reasonably confident going into consultation that we have a population served by the service who are happy with it, but we'll see, we'll test that out in the consultation. And yeah, we're also doing a you said we did approach. So live, we are taking comments from families, feeding back to them, this is what they've said, and then telling them what we've done about it. I think a basically happy workforce at Pilgrim, and I'm hoping a happy population served by it. I don't know if there's any more I need to say on that quick canter through. I'm happy to take conversations. The intent was just to show you that we have moved from the crisis through a couple of iterations of model to a model which is the one we now want to consult on, rapid assessment based, but with the ability to keep children and young people on the site for the period that they need to be here with us.
Okay, thank you.
Andrew, is that? Yep.
Right, Councillor Allen.
Thank you, Chairman. As one of the presenters said, this has been ongoing for almost 5 years now, I think. It certainly is before my tenure as a county councillor. If I'm making some errors because of lack of information, the presenters can no doubt correct me. But if I summarise it, it does seem that the situation is that prior to 2018, we were operating a fairly comprehensive paediatrics service at Boston Pilgrim, although maybe not delivering it at that time. We've moved on to, as a consequence of that, we've moved on to a 12-hour assessment sort of model with movement of particularly sick children to Lincoln, which seems to have changed over a period of time now to a more comprehensive service again at Pilgrim with regard to paediatric care, with much of the requirements for children's health now being dealt with at the hospital itself without having to move people to Lincoln, which I'm sure is very, very good. And I take it that's what the consultation now is, that we can provide fairly comprehensive childcare facilities at Boston Pilgrim that seem to suit most needs. And if that's what the consultation is about, because I'm not totally sure what the consultation is, we haven't got much information about it, but I take it the consultation will be that we now have a model which is working very, very well, and presumably we carry on with that as opposed to going back to the old model or to any other model. So hopefully the consultation will be a fairly brief one and fairly easy to actually assess and take the views that come from it in terms of making this model permanent. The question that I've got, if that's a reasonable summary of where we stand, is that it's obviously been more of a question of getting the resources to actually provide the service that should have been provided prior to 2018, and indeed to provide a service better than the model that was being proposed back at that sort of period of time. Does that mean that the trust is managing to deal with its recruitment and retention issues better than has been so in the past? Because it does seem that that is what's required to actually resolve some of these service provision situations. And indeed, I think we've got some further reports later on in the meeting where it does seem as though the issues that were causing problems in terms of providing services in relation to staff are also being resolved, and now we can provide some of the services that we didn't seem to be able to provide some time ago, Chairman. So I'd like the response to concentrate on the retention, on the resource provision that we're now being able to actually put into the service that's been provided in Lincolnshire.
Okay, sure. I see Simon's got his hand up. I'll give a quick answer to that question, and yep, Simon can either correct me or add to it. So I think your summary was an excellent one, Councillor. Absolutely, this is about a service that we've developed. What we now want to do is consult the public on making permanent a model that we think is absolutely fit for the future, is absolutely sustainable, gives great care to local children, and is absolutely about keeping a service at Pilgrim Hospital with minimal transfer of children anywhere else. So yeah, summary spot on. I mean, in terms of recruitment and retention, I mean, this is a trust that's now different to what it was pre-COVID. We've been here before about improved CQC reports. We've been here before about exiting special measures. And if you look at things like our vacancy rate, when I joined, I think vacancies were about 15% across the trust. We're now down to about 6%. Dramatic improvement. We now employ 1,000 more staff than we did back in pre-COVID. So a trust that feels very different, acting very different, and performing very different. And I do think what we're doing now around trying to make this service permanent at Pilgrim is absolutely cementing those improvements, making ourselves attractive to people who want to join us. But once they have joined us, allowing them to operate a service in a modern way that's about assessment, about treating people, and about making sure that that continues on the Pilgrim site. So I'll stop at that point. I know Simon's hand was up. Apologies, Simon, if I've just trodden all over what you're going to say.
No, you haven't. I think you've given a context there, Andrew. I was going to make a specific comment about recruitment into paediatrics. So I did want to take Councillor Allen to the consultation because he gave a much more succinct description of what I was trying to say than I could. But, I think the bits for me, when we were in 2018, this was very much perceived as a fragile service, not just by the organisations around Lincolnshire, but also by the staff within it. And we were seeing staff leaving the service. So even after the 12-hour model was put in, we were still seeing consultants leaving, nurses leaving. The model that developed after the sort of 2019 iterations, one of the things we did was make sure it matched with what we think is the Royal College of Paediatrics and Child Health's good practice models for acute care. And the other one thing that happened was we got CQC good when that was properly assessed after the report after 2019. All of that gave a positive statement to staff about coming to work in Lincolnshire and particularly in Pilgrim. And that's the basis on which we got consultants to apply for jobs and secure them in Pilgrim who weren't doing previously, because they were coming to a model they could understand, and there was a commitment from the trust to supporting that model. So the fragility was perceived to have gone, but our retention increased. And the CQC good moved more people here as well. So nursing recruitment into an organisation that's rated as CQC good on its paediatric service when neighbouring trusts weren't. We did find some qualified staff choosing to move to Pilgrim to be in a model they could understand that was getting described outside of our trust as a good model to work within. So slightly rambling, but I think the recruitment retention in paediatrics we will demonstrate in the full consultation was a very positive impact of us moving to this sort of assessment model, but with the ability to keep patients beyond assessment period on the site for as long as required. Thank you.
The chairman's given me the option of making a response to what you just said. It is very good news, and it does do what we're looking for as councillors in the chamber here. In terms of providing better services to the people of Lincolnshire, and it certainly sounds as though paediatrics within the Boston area is certainly improved. It's certainly has improved and certainly will improve. So I look forward to the continued success at Boston Pilgrim, and hopefully no more reports coming to this committee about having to change models in the future because of changes to the resources that seem to now being attracted into Lincolnshire. The success in terms of recruitment and retention in the trust is that an outlier within the National Health Service as a whole? Because we do continually get stories broadcast on the news about how difficult it is to recruit and retain staff in the NHS, and how nurses and doctors are leaving in drones, because it doesn't seem to be the case in Lincolnshire. And I would point out that I was eating lunch with a trust consultant who was still saying that we can't recruit and we can't retain staff in Lincolnshire, and we're still quoting the 14% figure. So I'm not totally sure whether the success that you're getting is being broadcast internally within the trust, and maybe that's something that needs to happen.
Shall I pick off on that? I mean, it's true that there are still recruitment and retention issues in the NHS. It's both variable between different geographical parts of the NHS, but it's also hard within a large organisation like ULHT to do what I sometimes do, just quote the very high level figures that overall our vacancy rate is 6%. So, you know, there will be some services that are more difficult to recruit to and more difficult to retain than others. The bit of that I don't control is the national pay part. So I have to rely on my national politicians for that one. The bit we can control locally is what sort of trust do we like to work in, both the physical environment, but also the behavioural and service environment. And what we've shown through some of the improvements that we've made over the last few years is that we can improve our position around recruitment and retention, and make a difference to things like sickness levels, which have also gone down quite dramatically. But I think it's always going to be a factor that we have to focus on really heavily about how do we attract people, not just to Lincolnshire, but to our part of the NHS, so the acute sector, and then within that, how we attract people to the Pilgrim Hospital part of ULHT. So I wouldn't want anyone to think that it's all sorted. It's not. It's better than it was. And our promise to you and our promise to our colleagues is that we will continue to focus on making this a great place in which to work, but also a great place in which to receive care. And I don't know if Suganthi, as a clinician, wants to add anything about the sort of clinical side of what we've just talked about. Thank you.
Do you want to mute? Thank you, Andrew. I think you summarized it very well. So there are, like Andrew said, there are specialties which are hard to recruit. With pediatrics in particular at Pilgrim, we've just been innovative in the way we actually advertise posts and how we actually, once staff join us, we've actually made sure both nursing and medical that they are well supported within the service. So I think that's probably what we have done differently to what we may have done in the past. Thank you.
Okay, thank you. I've got Councillor Overton next, please.
Thank you very much. And that was a nice presentation, and I think it certainly looks like improvements, and everything in the garden is rosy. I just would like, if it's going out for consultation, there's probably some things that you are already going to include, but it would be worth putting in. I'm thinking if I lived locally and had children, I would want to know that they could go to Boston. How many children are not actually taken there because they're going to need more than a 12-hour assessment? You know, and the children are thinking, well, it's only a short-term unit. If you've got something seriously wrong with you, you're going to have to go further afield to Lincoln or wherever. So I wonder, you know, the numbers are not there either. So I'd be interested in, you say you're not transferring many out of there, but how many are not arriving and not able to access their local hospital? Perhaps it's, as you said, there's not enough backup. I think maybe I didn't quite pick up whether there was a paediatric emergency support on site or not. So I presume that there are a number of children who are just not taken there. Then the second question is about the consultants. And I'm really pleased to hear that you've got nearly all the consultants you need. Are you having to pay a higher rate or anything like that, which is going to be unsustainable so that, as was alluded to earlier by a colleague, that can you keep a good performance, and that would be really good to see. And then thirdly, just to allude to the original point, really, is that it would be nice to see some evidence in there as well. I know you've said we've done this, we've done that, got 1,000 more staff. All of that sounds fantastic. Just about making sure that there are some outcomes to match, and that presumably would have some figures attached that you normally use to measure the performance of the outcomes of children that attend. Thank you.
Yeah, see, Saganthi's got a hand up as a consultant, and Simon, so I shall let my clinical colleagues jump in first.
Okay, shall I pick up? So if I just pick up one after the other, if I get it muddled up, I'll have to ask you the question again. So the first one was around transferring of children. Like we said, we will bring the exact numbers when we do the public consultation. But in general, what we actually have done is our A&E at Pilgrim is an unselected A&E. So we actually see all the kids who present to us, and then we triage them and then send them to appropriate levels of care. What I mean by that is if children are critically unwell, this is no different to what we did before. So if they're critically unwell, if they need HDU care or intensive care, then our tertiary centre is Nottingham, and Comet comes and retrieves those children. That's a transfer team. So we actually don't turn any of our kids away from Pilgrim at all. It is based on the clinical pathways, like we mentioned, we transfer the children out. In fact, some of the children from Lincoln Travel are being transferred to Pilgrim because our vascular services are here. So if you have a child with supracondylar fracture, we actually accept them at Pilgrim, and they are operated at Pilgrim. So that's the model in terms of, so we haven't turned, some of the pathways have changed. I think when we come to public consultation, we'll have the numbers. They may be due to service reconfigurations like ENT and what the other service, urology. But in general, children who turn up at our ED are treated, are triaged and resuscitated and stabilized locally. That's the first one. In terms of the consultant workforce, no, they're all on, the locum we have is also on NHS contracts, so we're not paying. But what I should also remind you all is that in 2018, it was a 1 in 6 consultant rota that we operated at Pilgrim. The trust has actually invested in 2 additional consultants as part of the model. So we actually operate a 1 in 8 consultant model at the moment at Pilgrim. What is the third question was asked about? Outcomes. Yeah. So again, that I think with the data, we will bring it to you during the public consultation. Thank you. I think so.
And I was only going to add, so I think we will bring length of stay information. We will bring the actual numbers of children who transfer off the hospital site when we come to back to you with the full public consultation document, and we'll take detailed questions on that. Just as an aside, and hopefully just to add as a reassurance, we are also monitoring the postcode presentations at Lincoln. So we will also be able to assure you in terms of whether it appears any of the population from Pilgrim are choosing to move away from Pilgrim because they're concerned about the model. I suppose the only point for me, Councillor Overton, is just the 12-hour length of stay model we haven't run since 2019. So we have hopefully got most of the population understanding they can come to an unselected ED and be supported behind that. We'll show you the stats when we come next time, but the critical bit for us in going through the public consultation is to make ourselves 100% sure that we've told the population very explicitly what they can expect at Pilgrim and given them that reassurance it's the right place to come. So hopefully we can reassure you when we come back with the full consultation document, but we do want to get to a stage where the whole population understand what is at the site.
Okay, thank you. I'll allow you to come back.
Yeah, it's just clarification. It might be because I didn't hear properly. Sorry if that's the case. But did I understand that you're treating all the children that come, and only some of them going into the hospital? I didn't quite understand that bit. But you did say you were treating all the children and not sending them directly, I think.
So we have an unselected ED, so emergency department. So anybody who comes to the hospital, their first line of treatment is within there. The ambulance service will obviously, if there's a major trauma so a major road traffic accident or something, and it's obvious that any patients on that need to be taken to a tertiary centre, they would choose to go to the tertiary centre, to a trauma centre. But actually, the bulk of the population, far and away the bulk of the population served by Boston, come to Boston. And we've got a paediatric service who are set up now for that, who work with ED, and who will pull children from there through onto the ward, into the ward area, and treat them, care for them as they did before 2018. When we get to the consultation, I think we'll probably be arguing probably better than pre-2018, but we'll save that for when we get into the open consultation. But the reassurance really is that the numbers of children who would need to go either not come to Pilgrim or go from Pilgrim to somewhere else are extremely small in the scale of things, and we will be debating that with the population and yourselves from June.
Thank you very much. That helps.
Thank you. I've now got Liz Ball.
Morning. Thank you for your presentation, and obviously most of you will know that I've got some knowledge about this service as well, so I am here from a Health Watch perspective and do want to target the questions from Health Watch. But Simon, you talked in your presentation, which I think was really helpful, about not having any complaints, and that the feedback is really positive, and that's really reassuring. And from previously, I know kind of harms were a major part of this review, that patients weren't coming to harm. So I wondered if you could give some assurance that there's been no patient harms as a result of this service, and perhaps that's something that can also link into the consultation. And then finally, just an offer from Health Watch is if there's any support that we can give in terms of promoting the consultation, then please feel free to link with us. Thank you.
In reverse order, Liz, I think, yes, we'd appreciate any help you can offer in terms of making sure that we publicise the events that we're going to put on and get that message out. The harm side of things, again, I don't want to drift into the public the detail of the public consultation for fear that we've started that process, but we have very, very strong governance structures for paediatric services at Pilgrim Hospital. We've had those since 2018 to reassure ourselves of what risk there might have been in there. Pilgrim is not flagging as any different from any other paediatric service in terms of everyone carries a degree of risk. There will also always be incidents and issues to investigate. Pilgrim is not anywhere out of the norm for national services in that line. And again, we will bring that back as data to reassure in the public consultation. But just for Health Watch and for the councillors, there is nothing flagging that suggests Pilgrim has any additional risk compared to its peers.
Thank you. Councillor Watt.
Thank you, Chair, and thank you for the presentation as well. I'm pleased that you've noted that the vacancy rate in the NHS in ULHT overall is 6%. You mentioned that obviously you've stabilised things in paediatric care. I wonder if you could elaborate what the current vacancy rate is in paediatric care, and if I may ask what the vacancy rate in other specialities, because you said it does seem to vary. And also, just for my own knowledge, forgive my ignorance, is all of ULHT's paediatric care, regular paediatric care, concentrated in Boston?
Andrew, do you want to do the bigger? Or do you want me to talk about paediatrics?
I was hoping you might talk while I try and find all the other.
Yeah,
we have It might be on the vacancies count, so it might be easy if I send Simon Evans a breakdown of all of the vacancies by our different specialties, just because I may struggle to find it in the time that I've got here. So if that's okay, Chair, I'll send Simon the breakdown. Not trying to avoid the question, I just don't want to give you the duff.
That's fine, Andrew. To be fair, you weren't meant to be coming to speak about the other areas anyway today, so if you could do that, that'd be very, very useful, I think. Thank you.
Yeah.
So I'll just in reverse order. So no, in answer to the question, is all acute care focused on Pilgrim? We've got acute paediatrics at Pilgrim and at Lincoln. They've both got on-selected emergency departments, and they both need paediatric services there. So the model is set up for acute paediatrics on both hospital sites. I would say that we're hoping that some of the stuff we do at Lincoln learns from the experience of Pilgrim. So we're looking at that early assessment model and how we utilise that in Lincoln. In terms of vacancies for paediatrics, I'm not going to be able to answer the detailed question, but I'll give you a flavour, and then we'll make sure that in the information that Andrew sends through to Simon, we include the detailed paediatric breakdown at the moment. From a consultant level, we've made the point that there are eight posts. 7 of them are occupied by substantive consultants, and the 8th by an NHS locum consultant, so paid the same rates as pay as an NHS consultant. And that individual we are currently working with to move into hopefully a substantive post through the next advertising of that. So we're hoping to get to 100% of posts occupied over the next 2 to 3 months. And there's no suggestion at the minute of anybody leaving, so they all seem to be quite happy. Middle grade tier, which is the doctors who are not consultants, it'll come through in the consultation, but just to be open with you, we recruited from overseas, we got them inducted into the NHS, did very well on that, and a number of them secured training posts then and went off to train to be consultants in the NHS. So we have recruited the next tier of those doctors in, and they are just settling into service, and we now are building an expectation that there will be a turnover every couple of years of some of those going into training, and we're just walking through that forward look, so we're recruiting in line with that. So we have had some gaps at middle grade tier. We're currently, I think, fully established, but we've got a few that we're supporting into their final stages of what they need to be able to do. Nursing wise, if you'd asked me the question 12 months ago, we were at, I think, 100% of our nursing roles covered. We now do have vacancies in nursing. And we're recruiting into those, but that's part of a normal turnover. So there's nothing happening in terms of the nursing establishment that makes us think anything other than this is people whose partners have moved out of the area, who have chosen to change career, etc. So we'll ensure that we send you the data through with what Andrew sends to you. But from the divisional perspective, we are comfortable that we have no issues with recruitment into the paediatric service at Pilgrim. We need to build that expectation of the middle grade tier turning over slightly and us doing something that pre-recruits to some of those vacancies with a bit of risk attached to that we might over-recruit occasionally, but we'll manage that. So we're happy that we'll send you some data that says we are happy with our establishments. It might look like there's a few nursing roles empty at the moment, but they are just part of a normalised recruitment process, and they are being recruited to as we speak.
Thank you, Chair, and I appreciate with anticipation the data.
Okay, thank you. Councillor Allen, you wanted to come back in?
Chairman, I think the submission to Simon will be very welcome, and probably the best way of dealing with it. It's not something really that we should be discussed in detail here, but it is obviously fairly fundamental to improving services in Lincolnshire, and indeed, will help justify some of the decisions that are coming out of the situation now, as we do seem to be able to recruit and retain more staff. Is there any way that geography could be put into it? Because I think specialisms will be quite interesting in terms of seeing whether it's a 6% across the board or whether there are still areas of concern. But I think geography might be particularly interesting as well.
I'll try to cut it as many ways as is understandable, but absolutely understand the geography side of it. So leave that one with me, Chair.
Thank you, Andrew. I'll allow you to come back in, Councillor Overton.
Thank you. Just a quick question. I'm very pleased that the recruitment's been successful, and you're clearly doing a good job. And if you're recruiting from overseas, I know you have to do more than just put the job out. You have to find accommodation and schools and all that. So that's clearly a good job. Well done. Do you mind me asking just which countries you've been recruiting from? You said overseas. I'm just interested where. Thank you.
I don't know if that's one for Scanthi or Simon.
Yeah, I can answer. Yeah, so in terms of nursing, I think it's it's very few overseas nurses because it's quite difficult to get children's trained nurses from overseas. So most of our nursing recruitment has been locally recruited nurses. People are moving from different areas to come and work with us on the back of our good CQC feedback, and the reputation has a trust where we are at the moment. With the medical workforce, some of them have relocated, 2 consultants relocated from Scotland to come and work with us. So that was really good for us. And then one of them was from Middle East, and I think a couple of them from Sri Lanka and from India as well.
Thank you.
India and Sri Lanka, yeah. Thank you.
Okay, thank you. I have no further speakers, so I've just got a couple of questions myself. First is, are you able to expand on the topic of private ambulances? Are they equipped in the same way an EMAS ambulance would be, and will they continue to be offered as this becomes permanent?
I am pleased to be able to report that we did away with the private ambulance 2+ years ago. So I mean, one of the issues that I said earlier on about them being unable to transfer the sickest children off the hospital site, they weren't full paramedic crews, so they didn't replace EMAS and our requirement for EMAS. But actually, as we developed this model and showed that we didn't need to move children off the site in any significant numbers, we dropped back into being a normalised user of the EMAS service, and we stopped spending any money with the private sector for an ambulance provider for children's services. Does that answer the question?
Yep, perfectly, thank you. And my second question is, on page 6, the report refers to feedback from families. Can you expand on where this has led to improvement or service changes, please?
We'll bring you some actual examples next time. We've done a fair bit of work with them around, are they happy with the service they receive? I think there's been some tweaks to how we've used some of the accommodation on that. We also engaged them in a piece of work looking at what should we do to try and update the facility, and we're doing more work with them on that at the minute in terms of what do they want the physical environment to look like. But a lot of what we did with them was that sort of reassuring ourselves that we were hearing if there were specific things that were causing them stress around either the model that we were running or the way that we were working with them. But I will get, for the consultation questioning, some examples of the you said we did, which we were running with them. It might be very, very operational, but I'll bring those to the next meeting, and we'll have them available for the public consultation so we can answer that question.
Thank you, that's brilliant. Okay, I'm going to, in which case, move to a proposal. So firstly, I'd like to thank our presenters. It's nice to have an item where you can clearly see that the views of people have been taken forwards, and I think it shows that by working with SOS Pilgrim, it's brought forward a service that is accepted and liked, which is very, very welcome. So I'm now going to propose we note the progress made in developing a proposed future service model for the paediatric service at Pilgrim Hospital Boston, to support the launch of a 12-week consultation seeking the views of the public on a proposal to make the current service model a permanent arrangement, and also to contribute to the consultation as respondents once it's launched in June 2023, with an update at that point. So do I have a seconder for my proposal? Councillor Allen, thank you. All those in favour, please show. That's supported unanimously. Thank you. And thank you to our presenters.
Thank you.
Thank you and goodbye.
Thanks, Andrew. Bye. We'll now move on to agenda item 6, the Manthorpe Unit, Grantham and District Hospital, extended temporary closure for enhanced dementia home treatment pilot. This item was circulated as part of the agenda pack on pages 23 to 34, and I'd like to welcome our presenters, Sarah Connery, Chief Executive for the Lincolnshire Partnership NHS Foundation Trust, Chris Higgins, Director of Operations for the Lincolnshire Partnership NHS Foundation Trust, and Andy Ricks, NHS Lincolnshire Integrated Care Board. If I can hand over to you for a quick run through, I think we'll take it as read and we'll take questions at the end. Thank you.
Chairman, I think we're just waiting for, I have messaged, because I'd asked the LPFT colleagues to get in for around 11. I think Sarah Connery will be here in a few minutes. I don't know if you want to take the work programme item now. I know you've kicked off this item, if that's...
That'll be absolutely fine. I mean, to be fair, I think we've been slightly light on district colleagues. It's gone a little bit quicker than normal.
Probably, yeah.
Yeah, so,
but there's certainly...
yeah, providing the committee's happy to move on to that, and then we'll jump back. So, thank you.
So if I could just ask the committee to look at pages 46, 47 onwards of the agenda pack. The items listed for the 14th of June do in fact include the consultation on paediatric services, which we were told was going to be launched on the 6th of June. So that will be available for the meeting, if not immediately issued with the agenda for the 14th of June. It may be a day or so later. We've got 2 items on GP provision, which will be able to pick up some of the comments that were made at the opening of the meeting about the additional funding. So I will ask that the report authors include those. Moving on to July, there is a long list of items in July, and I'm in discussions about how to fill those in. The definites for the July meeting are the Lincolnshire dental strategy and the fluoridation of water supplies, and also the outcomes of the consultation on community rehabilitation services. Sorry, that's mental health rehabilitation services for adults. So those are the definites. I'm just trying to work out how the other 2 can be slotted in over the course of the meeting. I'll take any questions. Thank you, Chairman.
Yeah, first I've got Councillor Wotton.
Thank you, Chairman. Can you confirm on the 19th of July the urgent and emergency care units will include the provision of the UTC at Grantham Hospital? Thank you.
The intention, Chairman, is that item, which is very broad, will cover the urgent treatment centres. At the moment, I'm still trying to work out which bits, but maybe it may be that we need to, having put them together in one item, we may be now moving away from that and moving to breaking them up, if that makes sense, into little bits so that they're more manageable rather than being a bigger picture of everything. But I will work towards getting some information on the urgent treatment centre in Grantham. Thank you.
Yes, Chairman, it's very important for the people of Grantham to have the knowledge and know what services are going to be provided at the UTC, particularly as it's 24/7 UTC. So more knowledge sooner the better. Thank you.
Yeah, thank you, Councillor Wotton. We'll ensure that takes place. Councillor Overton.
Thank you. I'd just like to pick up the 19th of July, item 4, the Developments in Mental Health Service, which I heard you say was about the rehabilitation. What I wonder if can be included in there is the issue of lack of beds for people who are in the community in dire need. And I have a resident who's been in this situation, and despite the fact that they were seriously at risk to themselves and others, there was apparently no space for them, and so they were left where they were. And obviously that puts a great deal of stress on the family and on the local community. So I wonder if that item is going to look at whether we've got sufficient provision to keep people in the community safe. Thank you.
Thank you, Chairman. That item number 4 on the list is developments in mental health services. It could be worked into that item. Item 5, the mental health rehabilitation, that's a slightly different aspect, but it could be something. That heading, developments in mental health services, will be, in spite of the fact it's just 5 words there, another significant item which is covering a number of things, and that one may also need to be split into different aspects. But I certainly can make a note of that and see if that can be addressed as part of this item.
Thank you. I think it's really, really important, very urgent and very worrying. Thank you.
Yeah, thank you. As I say, as Simon's already put, I would have thought developments would be inclusive of that anyway when we go to set it in the proper manner. So, but thank you. Councillor Smith, did you put your hand up? I want 100% soon. That's fine, thank you. Okay, anything further on the work programme? Obviously, anything else will be picked up as we now move forwards with the rest of the agenda, of course, going on. So, okay, that's item 8. We'll jump now back. I think, have we got our presenters, Simon? Lovely. So we'll move back now to the Manthorpe item. I will just reintroduce our presenters, but I won't go through the long titles if that's okay. So I'd like to welcome Sarah Connery, Chief Executive, Chris Higgins, Director of Operations, and Andy Ricks, please. And I'll hand over to you just for a quick run through. We'll take the paper as read, so just any sort of further update you'd wish to give, and we'll take questions at the end. Thank you.
Thank you very much, Chair. Good morning, everybody, and thank you for inviting us along today to talk about where we are around Manthorpe Unit. As you said, assume the paper will be read, but just for the piece of context that this programme of work is very much around keeping in line with the NHS vision to support people as much as possible in their own communities and in their own homes, to provide personalised care, more independence in their own homes, wherever that may be. So this paper is around Manthorpe Ward, which was an 18-bed ward in Grantham, caring for older people with complex dementia needs. The unit was temporarily closed in April 2020. It's a significant closure in terms of duration, which, as the paper explains, is as a result of COVID, and then the Grantham hospital site being deemed as a green site, which meant that inpatient services such as this did need to be re-provided elsewhere. An opportunity was there for us to make sure that we were still providing good quality care for patients, and so a dementia home treatment model was piloted. And the engagement that we've done with service users and carers and their families, as well as looking at clinical outcomes, has been very positive, so that we're now at the point where we would like to extend and expand this dementia home treatment team to provide even better care for the next 12 months, at which point through there we'll be doing enhanced engagement with the community, service users and carers and staff, to then come to a decision about the way forward. So I'll just hand over briefly to Chris to talk about the expanded model. Thank you.
Thanks, Sarah. Yeah, Chris Higgins, Director of Operations. So really pleased to be able to talk about what we're doing with the Dementia Home Treatment Service. And we've got home treatment services for a number of different groups of patients. And we've not had a service like this for dementia patients in Lincolnshire up until we tested out this new model. And what we've found is it's been really successful across a number of different fronts, that despite the reasons that triggered the change and operating without Manthorpe Ward, what we've been able to do is just provide that intensive home support for people who are quite obviously, people we aware, quite a vulnerable group of patients and their families. And one of the key issues behind this, and what ends up being one of the key benefits, is that with dementia, as people's mental health, memory deteriorates, that familiarity of a home setting is really important. Routine and familiar surroundings helps people to live well for longer, and those routines get really disrupted when you put somebody into a hospital on an alien environment. And we can see that quite often, that people get admitted to hospital and their level of confusion seems to be amplified quite dramatically at that point of admission because of that change in environment. And so sometimes that's necessary, because things break down to a point at home where we have to admit somebody. But by wrapping support around people in a really intensive way, with lots of home visits from our multidisciplinary team, we can keep people supported, help families understand how to manage that care and treatment in a better way, and people can stay well at home for a much longer period, and sometimes, for quite considerable length of time, so that hospital admission is not even needed. And that's what we've seen with the home treatment team. So really beneficial, and that's the feedback we've been getting from families, patients, and the carers, is that actually this is a better way of sort of working. People don't really want their loved ones to go into hospital, particularly for dementia, and it's usually a kind of point of last resort. And what we're able to do with this service is give that extra support so that people can care for the loved ones at home, which is what we're hearing is what people want to do. And what we're seeing in terms of clinical outcomes is that our remaining ward for dementia still has beds available, so we're operating around an 80% occupancy, so there's always beds available for those that need it. And we're seeing, so nobody's been admitted out of area, which we know has been a problem with other pathways in the past, but that's not been necessary in all the time that we've been doing this alternative model. And we're seeing that real reported feedback from patients and families about better experience, as an associated reduction in incidents, because as people move into unfamiliar environments, you see falls increasing and other things. So we've been able to avoid those kind of things. So all round at the minute, it seems to be offering a better way of delivering care. But what we're really keen to do now is test that out in a formal way. We've not done that to date. And also, as you'll see from the paper, that we've had to leave some staffing resource to support the other wards in the older adult and mental health in dementia pathway. But now COVID subsided, our sickness levels and absence levels have returned to normal. We can now release those staff so they can enhance the home treatment model even further. And just for context, there's about 20 staff that are operating that home treatment model at the moment. We can pretty much double that with this new pilot, and that's what we want to test out. So what that will give us is much greater capacity to be able to support more people at home. But also importantly, be able to reach into care homes. We're hearing care homes are saying that they need support, education, training, so that they can look after people that are placed with them for longer and feel more capable and equipped to do that. And so we'll be able to do much more of that. And also working with other partners like the ambulance service, like our colleagues in the acute hospital at ULHT, so we can support in there to help discharge and prevent admissions happening in the first place. So we're really excited about the opportunity to be able to test this out. But clearly it is a change in what we've been doing and change from that traditional inpatient model. And so we really want to test that formally. So do a structured pilot with a really structured engagement with patients, carers and stakeholders. And we also, which you'll see in the paper, is we've been working on other projects with the East Midlands Clinical Centre, and again engaging them in this piece of work, because that independent objective view of the model and how it's working and the impact of that's really important in terms of where we go at the end of the pilot stage. So yeah, I'll hand over to Andy. We've been working close to the ICB and who are working with throughout developing the model and are quite supportive, but I'll let Andy come in at that point.
Thank you, Chris. So simply to reiterate what Chris has said, and we've spoken before to the committee about the national direction of travel to try and enhance our ability to support patients in their own homes and in the community, because we know that people do fare so much better if they're able to stay in their home environment. And as Chris has articulated, extending the pilot for 12 months gives us the opportunity to really expand and test how we can maximise support, not just to people living in their own homes, but actually more importantly, or equally importantly, to those who are in residential home settings, because we know they also face significant challenges and require support. So the ICB are absolutely in support of continuing. It fits with a direction of travel that we as professionals and our clinicians and clinical leaders are very much behind, and I would hope that the committee will endorse the approach that we are taking, and if they see any further opportunities about how we could engage with the population of Lincolnshire to get a very rounded review and report, that would be very much appreciated. Thank you.
Thank you. Councillor Ray Wotton first, please.
Thank you very much, Stephen, Mr. Chairman. Thank you for your presentation. What strikes me about this report is the words temporary. All through this report, it's temporary this, temporary that. Yet on page 28, it says that the Board of Directors and the ICB recommend it for another 12 months. Do you not mean that it's recommended for a closure within 12 months' time? Because I see on page 27, you say very complex needs are still needed, and people are going to the Langworth ward, which is only an 18-bed ward. So 189 people going to Langworth ward, and 10 of those from Grantham. Surely there's a demand for this ward in Grantham, and not people having to travel to Lincoln. And my other question is, if the temporary pilot is extended and becomes a full closure, what will happen to the Manthorpe ward site? Thank you. Thank you, Chairman.
Shall I start and then others might come in? I think just in terms of the first question on that about temporary, it's one of these things, and I know that the committee's queried that terminology before, but within health services, it's something that we do intentionally, is rather than just launching into a permanent change. We like to test out ideas, and so which from our perspective makes sense, because you can then undo them or adjust them if it doesn't work out as you intended. And sometimes we're testing out quite different ways of working, and this is a good example of that, is that we've gone from an inpatient ward to a really new, first time we've done it in Lincolnshire, a home treatment model. And so we intend for that to be a temporary change initially while we test it out and test our thinking out and make sure it works in the way that it's intended. And if it doesn't, then we could potentially revert those changes and go back to the model we had previously. Now, all indications at the minute, as you'll see from the paper, is that actually this seems to be working. And so you could say, well, why aren't we moving now to a permanent change? But before we do that, we really want to be clear that this is the right thing, that we're doing the right model in the right way, and that we've really covered off all the bases and understood the full impact for people. So I think it is temporary from out, and that's probably the language we use most often, because it's intended that we want to adjust, review, and we could revert if the model turned out not to be successful. But I think what we're saying here, we're confident that it's the right way, confident enough to continue for another 12 months, and therefore let's remain as this temporary arrangement around Manthorpe Ward till we know for sure. But then a permanent change would have to be subject to a public consultation, and we would go through that appropriate process if the pilot suggests that that's the right direction to travel. But we're just not at that stage yet, so hence that language of temporary. The issue about demand, yes, there are some patients in Grantham, but you see about 10 patients over that period that require admission. That's much less now that we've got the home treatment team in place. That's not enough patients to warrant opening a unit of its own. And so what again was important to recognise is that both Langworth Ward and Manthorpe Ward didn't just take patients from around the surrounding areas. We admit to the first available bed, and so you'll see on the appendix to the report there that patients come from all over the county to both of those wards. And so that the important thing from my perspective, from a clinical perspective, there are beds available in Langworth Ward. We've got beds available, so anybody from wherever you are in the county will be able to be admitted, and that won't be delayed. And it's a really good unit. It's been purpose built. It's had a lot of money spent on it. It's a really great environment with a really good staffing team. We've just invested in a medical education centre on that building, so we can get specialist psychiatrists, specialists in dementia and old people's treatment that can work and be educated on site. So it's more of a centre of excellence that we're just not able to replicate in other parts of the county. So it makes sense from an estate environment perspective, but also the skills that we can wrap around people. But yeah, I'm not sure what the final question about use of the building to be decided. Again, if we do find that this becomes a permanent change in the future after the pilot, then there's options to consider. Obviously, that's a really a useful ward on a hospital site, so I presume there are multiple options that could be considered for the use of that, but nothing's been decided on that one at this stage.
If I could thank you, Chris, if I just add as well that we've always got one eye to the future. It's a really good challenge. So thank you, Councillor, in terms of what the bed requirements might look like in a few years' time. So we're doing some demand and capacity modelling in terms of an ageing population profile in Lincolnshire to make sure that we have got sufficient capacity going forward as well, which would have to feature into any of those discussions around future use of the building. I hope that's helpful. Thank you.
Thank you for allowing me to come back, Chairman. Why I say temporary? Because the hospital at Grantham has been temporarily closed since 2016. So we're now 7 years down that route without a decision being made. So I do question that. Now, can you tell me at the Langworth Ward, is it at capacity at the moment, or is there spaces there? Thank you.
I'm happy to comment on that. Yeah, I think just for clarity, the ward, it's an unusual length of time. It's been since 2020, so it's 3 years that the ward, Manthorpe Ward, has been temporarily closed, and that's unusual for us in terms of normally we progress changes and make decisions much sooner than that. But it was because of the impact of COVID, we were kind of a bit of a holding pattern for a while on that, whilst our staff were tied up supporting other areas. It's only now that we can really release that full staff team to really properly pilot what a full home treatment team could do. So, but it is unusual, and we acknowledge that. And normally we make decisions much quicker than that. It was just the circumstances around this particular case. And yes, there's capacity at Manthorpe Centre at Langworth Ward. Sorry, there's capacity there to be able to admit patients today, and there's the way that the home treatment work, we've always maintained about 10% of the beds available vacant, so that, or 20% should I say, so that there's space to admit people as and when they're needed. So in the 3 years it's been temporarily closed, there's always been a bed for somebody, wherever you are in the county, to be admitted to Langworth Ward if you need it.
Thank you, Chairman. Thank you.
Thank you. Before I bring in Councillor Allen, I'd just sort of add on to where Councillor Wotton's coming from. This constant use of the terminology, you know, this is a temporary basis. It just doesn't ring true anymore to any members of the public. We hear it over and over again. And here we are, another example in Grantham where you're calling it temporary, and in over 3 years' time, it still won't be open. I think the NHS as a whole needs to start looking at some sort of better terminology, because it does cause confusion. It isn't particularly fair on the members of the public, and it's time it's moved away from. Councillor Allen.
Thank you, Chairman. The point I was going to raise has been sort of not addressed necessarily, but at least acknowledged in terms of the responses that have come forward to some of the questions that Councillor Wotton's already raised. The issue that I was going to raise for response was the fact that the report does start off with the fact that the Manthorpe ward is predominantly provided for people with dementia whose needs are too complex to be safely managed within the community, which would suggest then that, you know, hospitals at home or whatever the terminology is may well not be the suitable location for these sorts of people. But in the response to some of the questions that Councillor Wotton raised, it's already been said, I think, that there is capacity within Lincolnshire as a whole for people such as that, not necessarily without necessarily providing a facility at Grantham. And if you look at the appendix, it's quite clear there is spare capacity at the Lincoln site, and particularly if we give precedence to people from Lincolnshire rather than people from London and St Albans and everywhere else in the country where we are providing space for those sort of people. So the question that I would, if that is available for the people that do require long-term stay in hospitals, if you go back to the premise then in terms of using the resources better, and indeed trying to provide for people with dementia in the care in the community sort of basis, because it's better for them than necessarily putting them into a ward with all the confusion that occurs. I mean, it may well be that the model that we're talking about at the moment is the better model to use. The difficulty then is, I think, the use of the word temporary, which you've raised, and indeed what the next 12 months might be used, because I was a little concerned that a lot of the information that we got in the report is reactive over the past 3 years. And indeed, I have a feeling that the situation over the past 3 years is probably not necessarily that helpful, because there's been such changes that have taken place over that period, and the people presenting with dementia may well have reduced as a consequence of excess deaths that have occurred during the pandemic period, and indeed beyond that. So I would like some sort of comment from the presenters, if at all possible, that the 12 months will be used. And it was mentioned in one of the responses that it's not simply looking at the reactive situation in terms of what's happened over the past 3 years, but we are looking into the future as well in terms of what demands might be required for dementia, as perhaps we get more and more people falling foul of that disease in a non-pandemic situation.
Yeah, shall I kick off there, and Chris, you might want to come back on a bit more detail around the expanded model, which I know builds on some of the learning from the initial pilot. I think it's a really good challenge about temporary I'm not sure whether we're able to call it anything else. I don't know what a suitable term will be, but we have to go through the pilot to ensure that we're doing the right thing before we can say it is a permanent closure. Hence why we haven't got options around the future use of the building, because we don't know whether we will be needing to opening it again as an inpatient facility. So, but you know, we'll certainly take that one back to the rest of the NHS system in Lincolnshire as well, around our conversations with the public on that basis. Just to say that this programme of work fits into a wider programme of work around dementia, transformation of wider dementia services in Lincolnshire. There was a dementia services review that was commissioned by the Lincolnshire County Council. I think it was last year or the year before. So we've got a dementia transformation board that picks up on those recommendations to make sure that we've got really robust community support going forward. We will always want to make sure people are supported to live well in their communities rather than an inpatient admission. The role has to be making sure we have robust support in communities and the inpatient provision is there as and when it is needed. As a result of the pilot, we've shown actually that we can do that safely without out of area admissions, as well as have some remaining capacity on the wards. So it is both of those elements together. I hope that's helpful, but Chris, you might want to talk a bit more about the expanded model based on the learning so far.
Yeah, so I think the trick here is that at the minute we're able to just reach into people's homes, and those people who are kind of we're getting calls, or our community mental health teams identify somebody that's their needs deteriorating, the situation at home is breaking down, and sometimes in the past it's been no alternative but to admit to an inpatient ward because the can't be managed, I suppose, and then the needs can't be managed safely at home, and hence that issue around too complex to be managed at home. But with that extra support that home treatment can offer, we can support people with more complex needs than we previously could, and we can equip families to be able to cope with that, because we can send people in to work alongside them, spend longer periods of time in the family environment to support people. And also now with the expanded model and those extra staff being able to do that with care homes, because we know that is people's home, that's where they reside, it's their place that they live. And so again, uprooting somebody out of there to go into hospital setting is not great, but being able to support people in that environment in the same way will help them maintain their residence and live a better and healthier life. And so the models were designed to do that, and the outcomes we're getting at the moment are really positive. I think looking to the future, though, we do know that the rise in population in Lincolnshire, there's going to be a significant rise in the number of older people. You can suggest there that might then lead to more people with dementia. And as you said, that we've lost people through the pandemic. And so that could lead to an increase in the number of people with dementia in the future. And so we have to model that out. And absolutely part of the pilot will be to understand that future modelling. We've already started some of that with system partners around bed capacity and other things. Now, if there's a rise in the number of people with dementia in the county in the future, it may be that we need more beds at some point, and we need to think about that down the line. We don't appear to need them now, but it might be that more community services are needed, and that will help and support people in a better way. We might find we need very few beds for dementia inpatient care because we can support people at home in a different way. And so it's slightly different to other illnesses where you need to go for medical treatments and other things like that. Most of dementia support can be delivered at home with the right support, hospital at home type services. So, but absolutely take the challenge. We are aware of the change in profile and population across the next few years, and we will be modelling what services need to be in place to meet that need. We're just saying here and now, it appears that we don't need all the beds that we previously had, and we can do things in a better way.
Thank you, Joey. Given the opportunity of coming back, you started to cover the question that I actually answered right at the end of that response, which is more looking into the future than using the reactive data that you've got to justify decision making that has an effect into the future. Because I think the real question is, will we continue to be able to provide the capability that's required across the dementia service as a whole if we do close the Manthorpe facility? And the question I asked in particular was, you know, will that information be considered within the 12 months before any decision is made to close the granted facility? In other words, you know, within this temporary period, which we may have to use before any decision is made to make anything permanent, will the future view be available to actually inform us whether that's a good idea or not? Because it would be a sad state of affairs to have another report coming to us in a couple of years' time saying that we've got to increase the beds that we've got available for the very sick dementia patients who need to be put into the hospital setting. Because if we have gone through a period where perhaps the demands for dementia support have diminished a bit because of the pandemic effects, and dementia is going to start increasing again across the county because of the demographics that we have in terms of old age. There's presumably always going to be a proportion that require some sort of hospital setting as they get further and further along this unfortunate disease and the effects become more and more serious. So it's just really a question of whether the future is going to go into the decision making as well as simply the historic data, which might be a bit poorly informed.
Yeah. In short, absolutely yes. There's a system-wide piece of work around demand and capacity modelling across the whole system, so that will feature absolutely in that decision making. The point I was trying to make, maybe not clearly, around the dementia transformation board is there is stuff that we can be doing now as a population to help prevent dementia in the future. It is, I'm going to do a shameless plug now, Dementia Awareness Week, Dementia Action Week, and I'd urge people, if possible, and I can support in getting involved in dementia research as well. So there is things that we can be doing now as a population to help prevent dementia prevalence in the future. So it is very much bolted into that piece of work. Thank you.
Thank you. I've got Councillor Watt next.
Thank you very much, Chairman. And I'm really pleased to see the report seems to be going well, and that there is capacity at the moment. But obviously, as colleagues have mentioned, we have an ageing population, and we know that there are going to be people who have complex needs who need to be in hospital in the future. I will say that for most dementia, people with dementia, it's good for them to be treated at home as much and as long as possible. I absolutely support that principle. I also note, though, that Councillor Wotton's point about people needing to travel, obviously people who are in wards like that will want to have visits from family and such like, and if they're a long way from their family, that's probably not going to be helpful for their treatment. So I'm glad that you are looking at having a study on future capacity. I suppose the anxiety is that we know, while there may be capacity at the moment, in the next few years, there probably won't be. It's really a question of how long we're willing to sit on an empty building in anticipation of that need, when there are other uses, presumably it could be put to within the NHS. So I would appreciate having the detail of that study, I think, as soon as possible. And I just want to ask as well, is this being exclusively conducted within LPFT, or are other agencies also involved?
Yeah, the bed modelling piece of work is a system-wide piece of work, of which our own beds is one part. So I hope that helps clarify.
Sorry, I didn't quite understand. What did you say last?
Sorry, so the demand and capacity modelling in terms of population needs going forward is a whole health and care system piece of work. So I hope that clarifies. But it is an ongoing piece of work.
Okay, do we have a time scale for when we might receive it?
I don't know to hand, Chris. I don't know whether you know when that piece of work is going to come to fruition.
No, I mean, what my particular suggestion would be that we have all the evidence we've got you'll see through the paper and the work we're doing, that certainly for the next 12 months, that demand is not going to change significantly, and that we can operate effectively with the number of beds that we've got currently open and with this enhanced home treatment team. But as you suggested, as part of that pilot, we need to really stress test that thinking for now and in the future. And I think you kind of hit the nail on the head there in terms of how long do you sit on an empty ward with all the staff in there when it's not currently needed. And that's the question that we need to test out, is that we're using the staff that are from Manthorpe Ward to enable this home treatment team to be delivered, and it seems to be effective. It might be that 5 years from now we might need more beds, but keeping a ward open unnecessarily for all that time and all that cost and not being able to use it for those resources for other things just doesn't seem quite right. But we need to really stress test that. So what we are saying here is that part of the pilot is that we need to really understand that. We'll feed in that piece of work that we're doing with the wider system. There'll be a thorough engagement process as part of the pilot to talk to patients and families, look at all the data, and that'll culminate in a report at the end of the pilot that proposes some way forward that will absolutely, certainly taking the challenge from the committee today, demonstrate that we've looked at that future modelling, made some predictions about what might be needed in terms of beds in the future, and be able to clearly set that out in a bit of a timeline. But here and now, the indication is that it's not needed, and it'd be unnecessary just to have a ward sat there empty. I hope that answers the question.
Thank you for that. So do you think that in a year's time we'll be looking at a report, perhaps considering a consultation on the future of the Manthorpe ward?
Yeah, absolutely. That's from a clinical and operational perspective. That's exactly where I hope this ends up, because it certainly seems to be a great way of working. It's evaluating really well. If we can manage people out of hospital, that'd be great. But I don't want to assume and presume without doing that proper piece of work and getting that independent review of the East Midlands Clinical Centre, really do that detailed work we just talked about there in terms of future modelling. So before we make some presumptions, we really want to stress test this new way of working, so that if we do present a case at the end of this that says let's move to a consultation, we've got some real clear understanding evidence behind that. And I just what we're saying here is we're not yet ready to make a proposal, because we haven't done that detailed and objective review just yet.
Okay, thank you, Chair.
Thank you. I'm going to ask a question now, because I think Councillor Wotton alluded to it, and I believe that Councillor Watt just brushed upon it. And that is that we do know that Lincolnshire is incredibly rural and often with very poor transport links. So how are you mitigating this for those who now have to travel further or more difficult journeys for either inpatient care or in turn for their friends or family?
I'm happy to pick this one up. Just there's a couple of different things we're trying to do. One is new modern technologies have helped with that. These types of calls really help, so that gives us much more quick access for people to be able to zoom in and talk to relatives that previously wasn't there, and actually it's enhanced something for those relatives even when they're quite close to home. But also what we'll be doing, and we've done it for other parts of our services, is that if families are really struggling with the cost of travel, then on a case-by-case basis, we will support that financially if we need to enable people to access visiting. So it's a combination of things really, and that's done with a conversation with families at that beginning point. If an admission has to take place, what's going to work for you, what needs to be put in place. And some people, obviously, it'll depend on distance travelled, it depends on their personal circumstances, but we would help people with travel costs if that was necessary. But obviously there's other technologies and other ways to keep contact as well to supplement that.
Okay, thank you. I've got Liz Ball now.
Thank you for your presentation, Sarah, Andy, and the question that I was going to ask was around the data, which I think colleagues have already asked, so we won't go down that one yet, and obviously that's something that's going to be provided in the future. But from a Health Watch perspective, we're also interested in whether there's any impact in terms of admissions to residential care and how that's impacting families both that would be funded from central funds, from government funds, or self-funding? Thank you.
Thanks, Liz. I'll respond to that. We haven't seen any evidence that the temporary closure of Manthorpe has led to a diversion of people who historically you would have considered required admission being admitted to other places. The cohort of individuals requiring support is pretty tightly monitored and managed and tracked. And my understanding is that they've all been maintained in their homes in the community through the team. I think one of the issues that might come forth in the future, particularly when we're talking about the ageing population, the potential for the increased prevalence of people with dementia whose needs might then become complex, is if the strategy of increasing community support and community resilience and subject matter experts and clinicians working in the community keeps people out of hospital, then the expansion into supporting care homes, and we know we've got quite a few care homes that specialise in dementia care, that it might actually be if we can make a very intelligent evidence-based assessment of, if we believe the prevalence will rise, where is the tipping point that might require additional beds, and where are those beds? Is it in a hospital, as in an NHS type hospital? Are we able to support people in their own homes, or do we actually concentrate our efforts on supporting people in specialist dementia homes that already exist? So instead of transporting people to an NHS facility, we reach in to support them and help with the education of staff, specialist knowledge, and so on and so forth. But to answer your very specific question, Liz, we haven't seen any evidence that people have been diverted into residential or care homes because of this current situation.
If I may, just to add, absolutely the case. And I think that when we're talking about helping people to stay at home and live well for longer in their own environment, it applies equally to that residential pathway as it does to inpatient care. So the longer somebody stays at home, the further we can delay the need to admit to a more intensive care setting, residential or inpatient. So by having these community services in place, hopefully there'll be less people needing that residential care. They won't need it till later on down their dementia journey as such, if at all. So hopefully as we expand the service out, we'll start to see even more benefits for not just health admissions, but delaying the need for residential care as well.
Thank you. I've got Councillor Smith next, please.
Thank you, Chairman. Excuse me. Whilst I fully appreciate and fully understand that for dementia patients, the best place for as long as possible to be treated is at home. My great-grandfather had dementia, and I can vividly recall seeing his in a gradual decline and then very quickly. As has already been said by colleagues, the data is very clear that very soon, in a number of years, we are going to have an increased elderly population, especially in Lincolnshire, because a lot of people who have been working professionals and etc. from usually the south of the country come here to retire. So we already nationally have a elderly population higher than the national average anyway, Chairman. This is going to expand. And what I don't understand, and I understand the point around you can't keep a building empty, but the NHS has, shall I say, passed form for repurposing buildings that were used for a previous purpose during COVID. Now, to my mind, surely that is a better thing to do so the building is not empty. I appreciate the staff may not be, who are currently there, may not be the ones who can stay in that building, and you have some staffing reorganisation to do, but surely it's better to keep that physical asset and keep it in use, because years down the line, if that building goes, and I appreciate nothing's been determined, but say it's sold, because that's often what happens in these situations where things are, as Councillor Wharton said, quote, temporarily closed. The NHS is then going to have to potentially find land that they haven't got at the moment to buy it, build a new building, and we all know the cost of construction has gone through the roof. And I have a real concern, Chairman, that actually what we're being asked to do is, it's great when relatives can look after their relatives who are suffering, but some actually can't, even at a low level of dementia. They mentally can't and physically can't, and others deteriorate quickly. What I don't understand is why it's continually an or rather than an and, because actually we're going to need this facility or a facility. And Chairman, it's frustrating to me because it's another centralisation in Lincoln, which is great if you're from that part of the world, but if you're for my residents or Councillor Wootton's residents, that's, with the greatest respect, next to useless. What will happen to a lot of my residents is they'll actually end up in North East Lincolnshire, who they don't pay rates for, who their tax doesn't go to their services, and they're going to be asked to take the strain because actually that's closer to them than Lincoln is. You've touched on technology around visiting. Yes, it has a place, but that does not replace physical interaction, physical touch, and physically being in a room with somebody. And petrol is only going to go one way, and that's up. And to get money for discretionary travel benefit, even when somebody is on universal credit, and I know because I helped an individual with this, it's not easy. It's very difficult. It's actually quite the process is actually quite intrusive, so a lot of people simply don't do it because it's that intrusive. And I appreciate you can't help everybody, Chairman, but I think we're on to a very dangerous precedent of it's an or, when actually it should be and. It should be working in the community and having this facility, and not continually centralising in Lincoln, which we keep seeing, which for vast swathes of our residents actually is simply not a solution or an answer. Because it's all well and good saying travel further, but when it's travel further because we're centralising everything in Lincoln, it's very hard to swallow. If it's travel further because, I'll use my case, they haven't got the specialisation in Lincolnshire, so I go to not. I can accept that because there isn't the specialisation in Lincolnshire, but when it's continually centralising in Lincolnshire, I mean, it stings. It's a bit of a slap in the face, actually, because we all pay into national insurance, and it's a good chunk of tax. And some of the residents, quite rightly, will be going, well, actually, why do I pay this? Because things are being centralised into one location, or you're being told to travel further constantly, and eventually North East Lincolnshire and North Lincolnshire are going to go, well, actually, we need to look after our own people and our own patients first. We can't take anybody from Lincolnshire. When that happens, you're going to be into a real problem, Chairman, because you're then looking into Nottinghamshire, Derbyshire, and even further afield, which again makes, in this case, travelling very difficult for relatives.
I'll try and respond to some of the comments you've made. One of the questions of significant importance that has clearly surfaced this morning is about what are our future needs for hospital beds for these people, and the answer is we don't know that yet, because whilst we recognise that that we have an aged population in Lincolnshire and a population that will continue to age, and theoretically that will lead to an increased prevalence of dementia, which theoretically might require more hospital-based beds. We haven't answered that question fully, and therefore aligned to that question is what beds do we need? And Sarah's articulated a piece of work that's going on at the moment to try and determine what will be the future requirement for bed stock for all NHS services in Lincolnshire. So we should have an answer to that in the not too distant future. But I'll come back to a comment I made earlier that we might not need a building such as this in Grantham or any other location, because alternative ways of providing support to people might be as effective and with outcomes that are as good, if not better. And there are other options potentially, which, as I've alluded to, could be reaching into specialist care homes who care for people with dementia that already exist. So it is a very important point, and it is a question that needs to be answered. And I absolutely agree with that. And I would expect, and Chris referred to this earlier, as part of this extended 12-month pilot, we need to make sure that no stone is left unturned in gathering the evidence and the answers to those highly appropriate and very pertinent questions about what the future needs to look like. But I've said before when I've attended committee, I have seen, as many others have over the years, the removal of institutions which at the time were felt to be the wrong thing to do, but actually have proved to be the right thing to do. We need to keep an open mind, get the evidence, present the facts, and make the decisions that are able to satisfy any question that is raised by any member of the public or any councillor or any other person who has concerns, and that's what we intend to do. I hope that is helpful.
Thank you for allowing me to come back, Chairman. And I take that point. The only thing on the care home thing I would say, Chairman, is during COVID, you had patients who were had quite complex dementia, and they were in these environments, and I admit they weren't specialist environments, but some of those stories, Chairman, were horrifying is not too strong a word, and they seem currently, and I appreciate a year is a long time, but currently I don't believe, from sitting on children's and other committees and having conversations with colleagues and officers, I don't believe there is sufficient number of specialist care homes that provide this specialist care which is needed in Lincolnshire. Now, in a year, that may be a very different story, and I accept that, but I would just urge we need to be mindful of that, because if we don't have that number, you're going to set things up to fail, and they're going to fail quite quickly, and the implications are going to be quite significant if that happens. Now, I hope that isn't the case, Chairman, but I think that needs to be raised, that I don't think there is the sufficient number at present.
I'm happy just to add, if that's helpful, is what's reassuring from the conversation here is that these are the very questions that we've been challenging ourselves with as we've been going and working to this point. And certainly the issue around travel that I think you mentioned earlier on, just to address that point, is Zoom calls and things are not the only answer, absolutely, and that there's nothing that replaces face-to-face contact with people. It's just worth always, recognising that in the current setup, whilst Manthorpe was open, people travelled all over the place already. This is not an unusual thing for people to move around to different places in the county to access that really small number of specialist beds. But what we are saying is that we're going to build in that support with travel costs to make sure that those that can afford to get there can actually access and support and have that face-to-face physical contact with their loved ones. So what I would say as well, to add to that, as part of the pilot, the engagement we want to do is really to test that out, really specifically ask around that transport question. Can people, do they feel able to access that contact in the way that they would want to, and what else might we be able to put in place to help that? So, but that will be a specific part of the engagement we do as part of the pilot programme. And just to pick up on a couple of other bits, one was just in terms of this, it is a conundrum, isn't it, that we see this growing population in the future. Does that mean there'll be more people with dementia? There's lots of ifs and buts around that, I suppose, in terms of the healthier lifestyles, other things that we're seeing, other evidence coming to demonstrate ways to prevent the onset of dementia or delay the onset of dementia. So an increase in population doesn't automatically equate to an increase in dementia prevalence, although we can start to make some assumptions around that as we do our modelling work. But here and now, I think keeping that building staffed and occupied just doesn't feel like the right thing to do. It wouldn't be good use of NHS resources, because we've got a staff, ward that's just not needed at the moment. The evidence suggests it's not needed. That's when the home treatment model's in place. We wouldn't have enough staff at the moment. We've heard about staffing pressures in the NHS to staff an inpatient ward and a home treatment team at the same time currently. And also we'd be putting people in hospitals that just don't need to be there, or the ward would just stand empty. And so at this moment in time, it doesn't feel like the right thing to do on a number of fronts. if in a number of years' time the door's open for us, and I think what we'd like to say is there's an annual planning process with the ICB and health organisations where we check what's going off, have we got the right numbers of services, what's demand looking like, what direction is that heading in, do we need to think about other services we need to bring online, and that's something we're continuously checking and through a formal process each year. If we get to a point where we see demand is increasing for dementia, we see that there is a need for an inpatient unit, 5-10 years from now, then absolutely the ICB, and I'm sure Andy would support this, the ICB and LPFT will work together to look at what's needed to put in place to put the facilities in place and have that set up. It's just at this moment, all indications saying it's not needed now and not for the foreseeable as we understand it. The other bit, just to say, finally, just to pick up on the point about care homes and the capability of care homes, one of the benefits of having this extended home treatment model is that we can increase the capability in the current existing care homes so that they can support people in a better way, and that having that extra capacity so our specialist staff can go in, work alongside the teams in those homes, help support care plan development and other things so that we can support people is intended to improve their capacity and capability in those care homes to support more people at home. So hopefully that will be seen and realised over the next year.
Thank you. I've got Councillor Lunderwood next, please.
Thank you, Chairman, and thank you for an excellent paper, because in my naivety, I thought that a lot of these patients came from the general community, but I've read in your paper a significant percentage of dementia admissions actually come from care homes. Do you actually have a breakdown that you could give me on that? And I've got a couple of observations and questions, please. The home treatment team, I believe you quoted there's 20 staff. Could you tell us what sort of a caseload they would have? And are they on 24/7 rotas? And is hospital at home linked to these home treatment people? And if I may go on, Chairman, the Manthorpe Centre actually took patients from all over the county, not just from Grantham. Yet in the paper you quote that in a certain period only 10 patients came from Grantham. We have loads of care homes in Grantham. Some of them are dementia homes, and obviously other dementia patients are within homes that aren't classed as dementia homes. So I don't think it really is a case of 10 patients. I think it's a relaxation of taking the Manthorpe Centre away, and like some of my other colleagues have already said, centralising everything in Lincoln. In the paper also you quote that dementia-related hospital admissions have reduced by 46% between 2020 and 2023. Well, the centre was actually closed. It was a green site. It was closed for COVID. And prior to that, you actually say here that the home treatment teams were already working between 2017 and 20. So theoretically, it was closed then. So everything seems to go to Langworth ward that would have gone to Manthorpe. So basically, I see it as, yes, we go through the consultation, but it's a done deal because the home treatment the home treatment staff are doing a good job. So I can't see us going backwards, and it's just a loss of more beds. But I do get it, if people can be treated at home. But I do see that as a lot of people are being treated in care homes. So that's what I'd like to leave it there. Thank you, Chairman.
Yeah, I'm happy to start and others can chip in. Just in terms of the running of the service, so it starts at 8 o'clock in the morning, finishes about 10 o'clock at night, does the home treatment team, and it operates 7 days a week. So that's making sure that we've got real extended support, and then overnight there's access to our wider crisis services in the organisation to support people. But we tend to be able to we'll keep that under review, and we'll review that as part of the pilot, but that tends to be the optimum time to deploy our kind of staff and support in those hours of 8 till 10 across the 7 days. It's in terms of the admissions prior to the temporary closure, there's about, I think there's 22, I think we said. It's about half the number of admissions that's required from the Grantham area specifically. That's because obviously home treatment supporting people to stay at home, and so only half the people need to go on to be admitted, which again obviously is an example of where the model's working well. Just to pick up on the point around the home treatment team, it was a different home treatment team, so we have dedicated home treatment teams for different services and different service user needs. So we have a home treatment for our children and young people, for example. We've got a home treatment for our older people with mental health conditions, so traditional mental health conditions like schizophrenia, depression, and that's the one that was running from 2017, where we've used the learning from that. That's been a really effective model. And so when we set up the dementia home treatment team, which is a separate team in 2020, it was set up at that point when we changed Manthorpe Ward, so it is only set from that time. And just saying in terms of caseload, I think the other question was, we're operating the dementia home treatment team as like a hospital at home model. We try to keep the caseload around the same as it would be if it's a ward, so around 18 to 20 people. We sometimes go a little bit more than that, 25, depending on need, but we keep it as a very tight caseload. And so that's the difference between some of the other community services where you'll see somebody once every couple of weeks or whatever for a routine appointment. This is an intensive support of a team of, a highly staffed team for a small number of people, so we can provide that level of intensity that you might get in an inpatient ward, but at a home environment, which is why it's so successful. So that caseload is monitored and reviewed, and make sure that we stay within a reasonable number, so that we're able to provide that intensive support. I hope that's helpful.
If I can just come in on around the why Lincoln question, which I think is sort of a bit of a thread, that the Manthorpe estate was not ideal, and before COVID we were looking at what level of investment would be required to bring it up to a state-of-the-art facility. At the same time, a business case had already been approved for the development of the Lincoln site, which is at Witham Court, which has now been successfully completed. So it is absolutely brilliant estate, which is what our patients should expect and deserve, and the facilities that our staff should expect to work in. So it's more about availability of good quality estate, as opposed to making everything Lincoln centric. Thank you.
Thank you. I've got Councillor Overton now, please.
I want to pick up the point about the few number of people that you say need this facility. It does also say that Lincolnshire is an outlier in that we have one of the lowest proportion of people who are admitted, one of the lowest admission rates, and we're outliers. So I'm wondering how you can assess success. Are you counting how many people with dementia fell over on their way out the door, or lay down on the snow and died, or had to be hospitalised from that? Are you counting the number of times that the police were called because somebody was in the road or lost? So I'm just wondering how you count success here in the project. I can see that those who are getting the service will certainly be getting a good service, and I'm sure that's right. I'm sure that you're doing an excellent job for those. My worry is that it may be too much for the community and the police and all of the other services that are needed. On your point that you made about the homes, and I was interested in Councillor Smith's point about whether there are enough of these homes, you do list at the bottom, on page 27 at the bottom, the different people who might be needed to provide support for these people. So you've got pharmacy, social workers, occupational therapy, psychologists, dietitian and physiotherapists. Not many of those are in LPFT. So if you are putting these people, if more of these people are in the community because you've changed the protocol and are only taking the more extreme cases, where Lincolnshire is an outlier, only taking those very extreme cases into hospital, it does mean that we're going to need much more of the other services in the community as well, because clearly LPTF, you don't work alone, naturally, you're not the only people who are needed. So I'm wondering if you're going to be looking at those other factors. Can we see that the PCSOs that we've just been told are going to cease from the 1st of October in the whole of North Kesteven, except for 2 in Sleaford? No
Councillor
PCSOs.
Overton, I think we're wandering off. This is an NHS-based services. If we can keep it based on the NHS services, please.
Yeah, the point is that if you're moving people into the community, they're going to need more other service as well. And one of the speakers did talk about taking a holistic view in answer to Councillor Watt's question. And I think it does mean that we have to work together to get all of the other services engaged as well. More care, more respite care, all of those things will be needed as well. And I hope that that will be part of the consideration. Thank you.
Thank you very much, and you're absolutely right. We work incredibly close. We try to as much as we possibly can with all of our system partners, and that does include the police and the Police Commissioner's Office as well. The Dementia Transformation Programme Board it's a very collegiate and diverse group of partners, including the voluntary sector as well, and Age UK. And care homes and primary care. So we make sure that we're hearing all the relevant voices in that piece of work. In terms of those roles, where it makes sense, we will recruit. We already recruit social workers, occupational therapists, dietitians, physiotherapists. So we operate in a very multidisciplinary team way of working, trying to wrap around the person as much as possible and picking up all of their needs. So we already have physiotherapy within our older adults division, for example. It's just an expansion of that, using those resources, just for clarification. It's a good challenge in terms of what do we measure to ensure success. If we go back 4 years, we had 4 older adult wards and lots of people going out of area. We now have 2 older adult wards and we have no people out of area. So I think that should be celebrated for Lincolnshire, and I think we are a diverse and rural and coastal community with lots of diverse needs. Within our finite resources, I think we do a good job working collegiately together to try and be as innovative as possible. We use those inpatient benchmarks as a way to sort of see, have we got it right? What are we measuring success? But people do look to Lincolnshire and they want to come and talk to us about those models, because based on our service user and carer feedback, we don't always get it right. But what the pilot engagement process has shown us is that this is a model that works for families and service users. So part of the pilot will be, talking to service users, what should we be measuring as our measures of success beyond out of area? We look at length of stay, for example, but we're really interested in how does it feel? Did you feel supported? Did you feel heard? And a big thread of that Dementia Transformation Board is support for carers. One of the councillors has mentioned it already, that we need resilience and support for our carers, or the model will not work. And I don't know whether Andy and Chris want to add anything there.
Yeah, I'd quite like to add something. Thank you, Sarah. I think that the questions and the observations and comments were made are the very reason why we undertook an extremely comprehensive review of dementia services within Lincolnshire, and that was done in concert between the NHS and the local authority of Lincolnshire County Council, because there was a concern that services for these individuals and their families had grown up in a way that was a bit piecemeal, a bit fragmented. We weren't convinced that we were joined up enough between social care, between healthcare, the voluntary sector, and we wanted to step back and take a view of what have we got, how is it working, what does good look like, and what do we need to do if we're not in the place where it looks as good as it could be. Sarah's mentioned the Dementia Transformation Board, which is multidisciplinary and subsumes all of the appropriate organisations in Lincolnshire that you would expect to be around the table. And we are looking at investing money into supporting the whole of the dementia care pathway, of which LPFT makes a contribution to. They don't hold the responsibility for everybody with dementia. They provide specialist care for those who are probably in the most difficult of situations and support families who are in the most difficult of situations. But it is a societal response, and we all have something to contribute and a role to play. And I expect that the work of the Dementia Transformation Board, based on the recommendations of the system review, will get us into a pretty good and resilient place, and will identify the gaps that we can then find the funding for to make people's lives better. Thank you.
Okay, thank you. I've just got a couple of questions myself, and then I'm just going to move to the proposal after that. So my first question is, on page 28 of the report, it refers to using existing resources in the dementia care pathway to expand the services in the pilot. Will a transfer of these resources impact on Langworth Ward?
I'm happy to respond to that. The answer is no. What's been happening is that up until now, some staff have been redeployed into Langworth Ward and into actually one of the other wards neighbouring that to support during COVID. And what we've seen is that those, because the sickness levels have returned back to normal following the impact of COVID, we're able to release those staff without any impact, and we've got a full resource team on both of those wards now, so they just don't need the extra staff anymore, hence we can release them into the home treatment team.
Okay, thank you. My next question is, when will the East Midlands Clinical Senate begin their evaluation of the pilot?
Again, what I would say on that one is we're really waiting till after today. Once we're clear and the recommendations from the committee, we'll then seek to engage the Clinical Senate. Recent experiences, they can be engaged quite quickly, but we'll probably, as the indicated paper, we're setting up the pilot to begin in July will be the intention, and so we'll engage them to start from July onwards, but will be dictated by them in terms of the timeframes. But the intention would be that the outcomes of our own local pilot and the report that will result at the end of it will incorporate all the findings of the Clinical Senate as well.
Okay, thank you. In which case, then I'm going to move to the proposal, and I propose that we note the report on the continued pilot of dementia home treatment and the extended closure of the Manfort ward at Grantham District Hospital, taking into account the continuous public engagement and involvement carried out on the service developments to date, to endorse this continued engagement approach for the period of the extended pilot to help inform next steps, and to welcome the involvement of the East Midlands Clinical Senate in evaluating the pilot, and to request consideration of the Senate's report when it becomes available. Do I have a seconder for my proposal? Thank you, Councillor Linda Wootton. All those in favour, please show. Thank you. That's supported. Those against? Abstentions? Thank you, Councillor Overton. Okay, that's carried. Thank you. And thank you to our presenters for that one. I know it's over to you again for agenda item 7. So we'll now move on to the temporary closure of Lincolnshire's Males Psychiatric Intensive Care Unit, the Hartesong Centre. This item was circulated as part of the agenda pack on pages 35 to 43. And if I can hand over to our previous 3 presenters, who's going to present this once again. And again, we'll take the report as read and let you run through and take questions at the end. Thank you.
Thank you very much, Chair. So I'll kick off again. This is another paper around a temporary closure of a ward in Lincolnshire, but I can't underline enough that this is a very different set of circumstances in terms of this temporary closure. Personally, I've fought, and the other people around this screen have personally fought very hard for psychiatric intensive care provision in Lincolnshire. We haven't always had it. It needed significant capital and revenue investment in order to provide that service. And similarly, we are fighting very hard to be able to get it open again. So we're embarking on quite a significant and how I'm framing it, aggressive recruitment campaign to make sure that we can get the unit open as quickly as possible. So the reasons around this decision, it was very much a clinical decision around patient safety, where inpatient vacancies across the whole of our inpatient division, as a result of, we've previously talked to the committee before about expansion of community services, which has, people working in inpatient services have seen that as an attractive proposition. People retiring post-COVID has left our inpatient staffing quite fragile. PQ, it was a difficult decision to temporarily close it, but it was seen very much as the least worst option in terms of making sure that we can keep as many patients safe and in county as possible. So we're giving an update in terms of where we've got to around the engagement. And at that point, I'll hand over to Andy. Or Chris, if you want to come in first, Chris, sorry.
Okay, I'll just add then, just to say, I mean, I think, as Sarah said, I think what's different to the other proposals that we've talked about, and I just want to address the issue about temporary on this one, is that we're not trying out an alternative community model here. This is not something where we've gone, we're going to, test out a home treatment model as an alternative, and at the end of this, we'll go, oh, there's a better way of doing it. In this circumstance, we've temporarily closed something, and some patients having to travel outside of Lincolnshire for care, which is not what any of us want, and we haven't got a plan B in place to do an alternative way of supporting that need, and nor could we at the moment. So the all steam ahead to try to get the staff in place to reopen this unit. One of the things which Andy might pick up when he speaks as well, though, is one of the challenges we've heard as we've gone through the engagement work with particularly stakeholders across patients, carers and professional groups is don't lose sight of the female pathway here, and that actually is there a way you can do something in the future to support female patients. And so we are looking at that at the same time, but all indications are all recruitment activities got going off. We believe, we're confident that we can get the unit open in part in November and then look to a full reopening next year. But just for context, we've only got 2 people out of area at the moment in male PQ. So if we get to a place where we can open 4 beds, that will manage all the current demand, but will give us that extra capacity as we move to a full opening if we need it. But as I say, we are trying to address that question along the way and working with our clinical teams to say, what could we do differently around that to support the female patients as well as the males? So I'll pass over to Andy.
Thanks very much. This closure is totally different to Manthorpe because this was done on essentially the grounds of clinical safety and risk to patients, and was a proposal that really was led by the senior clinicians within LPFT, because they could see the potential for risk to individual patients and staff. So it was a decision that was not taken lightly, and there is every intention that unit will reopen. There's no question about that whatsoever, but it will be open when it is clinically safe to do so. And there is a plan that hopefully will be by November on a phased basis, or sooner if possible. And as Chris has said, when we put all of the investment in to open the male PICU, it was because there was significant demand for male beds and virtually none for females. That situation has sort of reversed. We now probably have a critical mass of female patients to make a unit in Lincolnshire viable, whereas before it just wasn't. And we were in conversation with NHS England regionally about whether we could team up maybe with Nottingham. But now it feels that that is something that we should be able to do ourselves. So, I mean, in summary, we didn't want to close it. We felt we had no choice. Reputational risk to LPFT was not the major concern. Clinical risk to patients and staff was the major concern, and the unit will open again. We're absolutely committed to that happening.
Okay, thank you. First question I've got from Councillor Allen, please.
Thank you, Chairman. I think it was only 6 months or so ago that they came to us saying that they had to close temporarily the Hartsome unit because they had to put, I think, the staff that were there into the greater mental health provision, and that it wasn't that the inpatients could be managed in a slightly different way. I've been through the report and I can't see anything that's significantly changed since they came to us. You know, it doesn't seem as though the figures indicate there's, you know, there hasn't been currently a success in terms of recruiting more staff or significantly reducing turnover, significantly recruiting staff. The thing that seems to have changed significantly is sickness. Maybe staff, you know, work better outside these units than they do inside the units, and maybe that's the equivalent to that. So I'm not totally sure. I'm fully supportive of the issue in terms of, you know, reopening it, because I, you know, go back to the comments I made earlier in relation to the dementia report. I think there is a growing demand for this post-pandemic. We've got 2 million people or whatever it is that are currently out of work, with mental health issues being a significant reason for that. So there seems to be a growing issue, perhaps in terms of mental health support. So all these things would be helpful. So I don't have a problem with the proposal. What I really just don't understand is how we got to a situation that's changed so significantly in 6 months, because the figures there don't seem to show a significant change. There has been significant work in the hospital, and maybe that was a reason for moving people out of it, but I dare say that would be not the case. And there is a need to bring a relatively few number of people back into Lincolnshire who are currently outside Lincolnshire in facilities out of county. It may well be that this growing number of mental health issues is already increasing the numbers that allow us to perhaps consider the need for 2 facilities, maybe 1 female and 1 male, I don't know. Perhaps it could be expanded upon, because I really don't understand. I'm fully supportive of it, but I just don't see what the changes that's taken place over 6 months, and I would like to understand that.
Thank you. Thank you for the question. Absolutely the right question to be asking, and I think that the important thing to note here is that we're in a deteriorating position at the point of the closure. So vacancy rates were increasing and got to a critical point. And although it's a slight improvement on that position, it's an improvement, and that's a turn the corner, I suppose, is the best way to term that. And from being a deteriorating position over quite a significant period of time, we've now seen an improvement, although it be quite small at this stage. And I think then what we're saying, coupled with all the additional activity that's listed in the report, particularly all the recruitment campaigns, and we've employed recruitment agencies, we've put posters on every petrol pump and bus stop in Lincolnshire and beyond, and we're making some assumptions, a series of assumptions around the impact of that additional recruitment activity and what that's going to do in terms of staffing levels. And we've got some reasonably sophisticated workforce modelling tools that you can apply your different assumptions to that project where you're going to be in terms of staff turnover and recruitment success in the months and years to come. And through that tool, we're saying with the combination of what we've done today and what we're planning to do around recruitment and retention, we've got confidence that we're going to see that position of recruitment and vacancy reduce and recruitment increase. It's, we are looking at a bit of a crystal ball here, and I don't want to sit here and say, we're absolutely 100% confident that that's going to happen. We're confident in the actions we're taking. We can't see other actions that we could do to try to recruit and improve that position. And looking at successes we've had in other areas around recruitment, we're confident that the same rules will apply to this situation, and therefore we will be able to recruit the staff. But we're going to have to do a bit of a stock take, probably September time, just to see, has everything that we hoped come to fruition? Has it not? But at this moment in time, we're saying that with everything we're throwing at it, we believe that we'll get the unit back open in November, but also taking that guarded approach, really, that and a bit of a pragmatic approach, that rather than trying to open the unit in full, let's open it with a reduced staffing capacity at 4 beds only, just so that we can get it open, we can meet the need, and that gives us a bit of a breather so we can do more work over the course of next year with the intention to open it in full in the March after. But we've still got some staff, those staff that were originally employed at the PQ have been redistributed. We can pull those staff back in. So we have got the core of a team there. We just need to build that up over the next few months. So, but absolutely right challenge, and we won't know the output of all that work until probably 3-4 months from now, as we see how many people apply and what that results in terms of staffing levels.
Thank you. And just to add to that as well, you can see there's sufficient focus as well on retention. It's not just about necessarily increasing numbers, it's making sure that we've got a well-supported, well-trained staff force who feel equipped with the skills to be able to provide safe and effective patient care. So you'll see from the paper as well the focus we're putting on staff retention. Thank you.
Thank you, Chairman. I fully support the confidence that's been expressed in terms of achieving the recruitment that's going to be required to certainly get the thing operating fully in the longer term, never mind opening in its reduced term. I would point out that, as I said earlier on, that the turnover rate and the vacancy rates changed a little, although they're still below targets, and I hope those targets aren't the targets as required to actually do the sorts of things that you're talking about. I would say that I'm fully supportive of the proposal that we've got. It's just that I wasn't particularly supportive of the temporary closure 6 months ago, and I'm very glad to see so much change that's taken place over the past 6 months. I would also be very supportive of the excellent amount of engagement that's taken place during this course of this 6 months. It was quite considerable in relation to the original proposal to temporarily close the unit, and it's been equally extensive in terms of actually determining what the impact of the closure was, and no doubt led us to the decision now to reopen it temporarily, but fully over the next 12 months or so.
Thank you.
Thank you. I've got Councillor Overton next, please.
Thank you. I promise not to mention PCSOs. Just like to bring up a different issue, if I might, which is about making sure that there are enough beds. And I'm really, really pleased to see this coming forward, because I understand from what residents tell me that there is a real problem with, serious cases not being able to get the support they need, because they need, professionals think they need to be taken in to get a longer term and closer attention. So I'm really pleased to see that you're working so hard to get this open, and thank you very much indeed for that. I would like a little bit more thought, a bit more detailed ideas about how we might get a women's unit, because as I understand it, that is actually the biggest need at the moment that's come to me anyway as a councillor. So I'd appreciate a bit more work on that if possible. I'm sure you're going to, but perhaps you could just give me some more thoughts on it. Thank you.
Do you want to start, Chris?
Yeah, I'm happy to start on that. So yeah, absolutely. And I think just pick up on the point of the wider pathway. Often the beds that you've been talking about is access to kind of acute mental health beds when people are really suddenly become quite poorly. We know that those existing wards are kind of running with quite high occupancy levels, so that can be a challenge at times, particularly when we've got peak demand. And so the PQ is part of that solution, but also the other community work that we're doing, which we'll speak to the committee about in the coming months, is really going to hopefully help to reduce that need for admission for some people, so that admission and the beds are reserved for those that need it most. But again, we can probably update that in the future, but the PQ is an important part of the pathway for us. In terms of the female pathway, I mean, you can see that the numbers in terms of vacancy rates and the staffing position that we've got, and what we talked about at the committee before. The idea of opening another ward now on top of this ward in the next kind of few months is probably unrealistic. And so we do need to think about how do we meet the needs of the female population. What I would say on that is I'm working quite closely with our other leads in the organisation, so our Director of Nursing and Quality and our Director of Medical Director, to look at different options that we might be able to do with our existing resource. Can we move things around and do things slightly differently so that we can accommodate those females back in Lincolnshire with the same resources we've got now? Or is it a longer term plan that we need to build something separate and set up a new ward with and a whole new staffing team? And so I think we're not there yet, but over these next few months, we're working to develop some options around how we might be able to meet that need in the future. But certainly as an organisation, certainly ICB, I'm sure Andy will support, are committed to supporting those patients in Lincolnshire. We just need to look at how we can achieve that most pragmatically.
Yeah, I think a key requirement will be flexibility as well, and Andy touched on it earlier in terms of these are small numbers, but they do change significantly from year to year and between the genders as well. So it's going to be we need to put some real serious thought behind that modelling piece of work to make sure that we get that capacity right, but to make sure that it's future proofed as well for changes in that demand. Thank you. I don't know whether you wanted to add anything, Andy.
Yeah, I think the numbers do change. I made reference to when we opened the PQ originally. We were looking at a demand of about 10 males at any one time requiring that service, and about 3 females. That's now switched to about 7 females and 2 or 3 males. So if we're going to expand we will reopen the male. We've said that's absolutely going to happen. But if we need to provide a facility for females, and maybe in a year or two the numbers switch again, we need to have a facility that has the ability to be really flexible, because we can't back ourselves into a corner and say, oh, we've got this brilliant facility, and then go, oh, but we only put 5 male beds in and 5 female beds, and now the numbers are moving around. So we've got to give it some real thought, because to set something up to not work in the long term and be agile would be a bit of an epic fail, really. So we want to get it right. So we'll get it right rather than get it rushed. And yeah, I'm really confident that will happen at the right time. Thank you.
Thank you very much. Just to come back, I think the point about making sure that the beds are available is that if we haven't got enough beds, it puts a lot of pressure on the staff as well, and then obviously that impacts on recruitment. So I appreciate that you're working hard on it. Thank you.
Thank you.
Thank you. Councillor Smith.
Thank you, Chairman. I appreciate they may not be able to answer this question because it's a bit of a crystal ball question almost. What caused the shift? Because men's mental health is not, excuse me, as a rule, drastically shot up and increased in its, shall I say, its well-being. Stats don't back that up. They may not be at the high-end level, but the number of men who are suffering some form of mental health is only going one way, and that is up. So my query is really around how has the numbers changed, and also for those that don't reach, say, the PQ level, what support is available to them. And I mean, especially around men's mental health, because how men deal with their mental health is obviously very different to how females deal with it, by the very nature of we think differently, we act differently, and is there not specialists, but is there practices in place that acknowledge that difference? Because whilst there are commonality in how you can deal with it, I think it's important to also acknowledge there are differences, and what may work for one sex will not work for another.
Yeah, I'm happy to respond to that. So, in terms of why we've seen demand change over time, there's nothing fixed on that, and we may well see numbers rise again in future. I think because we talk about such low numbers, we're in single digits here in terms of the demand over time. It does fluctuate. You know, in previous years, as Andy's references, that we're kind of 8-10 people requiring this, males requiring this level of care and treatment. Over the last year, it was averaging around 4 and 6, somewhere around there. And this year seems to be just a lower point in terms of that, about 3 or 4 or 2 or 3 people at the moment. And so it does fluctuate, but I think it's just because we're talking such low numbers, there's no real hard and fast evidence to suggest there's anything that's causing that, which does make it interesting in terms of planning service delivery, because you've got to have something that can cope with that variation in demand over time. And so we do know of units have got mixed gender units, mixed sex units in and around the country, that we're interested to go and have a look at how they're operating them, because that means that you can flex the number of beds that you've got for both males and females as that demand changes over time. But absolutely, it's acknowledging that different needs of the different population and making sure that you've got the right skills in place to deal with both. And as part of the work we're doing is having a look at some of the units out there in the rest of the country to see how they're operating it, what does best practice look like, and using that to inform our own models here in Lincolnshire.
Thank you. I've got Councillor Watt next, please.
Thank you, Chairman. And it's quite, I may say, first of all, it's quite refreshing to hear you guys fighting to keep a ward open, rather than the sort of professional pessimism I think we're used to hearing in this committee. So I really do support your efforts in that regard, and I'm glad you seem to have the support of staff. I'm really hopeful what you're saying about retention and recruitment is true, and that you can keep this ward, or reopen this ward, I should say. I'm also interested in the premise of Councillor Smith's question. I'd be very intrigued to know what has caused that shift. Perhaps that's a bigger piece of work beyond the scope of this discussion today, but I'd like to know if you are doing any research along those lines, and if that's planned in the future. But I also wondered what the relationship is with other units, and again, forgive my ignorance if they don't provide quite the same service, but obviously you do have facilities like the Peter Hodgkinson Centre, which does have a female ward. And I appreciate the situation, those facilities can change quite quickly, but is PHC covering that demand, and are other facilities in Lincolnshire meeting that demand as well? Thank you.
Thank you.
Yeah.
Do you want to start, Chris? Sorry, yeah.
Yeah, no, that's fine. Yeah, just happy to start on that. Yeah, happy. In terms of the Peter Hodgkinson wards, is just understanding the different levels of care and treatment that we offer in that kind of specialist end. Is that we've got what we call acute mental health wards that can deal with people's, well, as the name suggests, acute mental health crises that come up, to give care and treatment at the point where people have got a flare up of their mental health or a deterioration in their mental health, and need a real intensive support in an inpatient setting. And that's what the wards at PHC and similarly the ward at Ward 12 in Boston and Ashford in Sleaford can provide. The PQ comes in that next level up, and it's just where people might be displaying aggressive behaviours or self-harming behaviours that are at a level that's really difficult to manage in a more open ward environment, need a high level of staff to patient ratio, need a more secure, less stimulus, low stimulus environment, and that's what the PQ can offer. And so it's for males. We've always had that service in Lincolnshire. We've had it since about 2017. Never had one in Lincolnshire for females, and so at the minute, this what we reference is that females and males can be supported for their acute level need, but if they need that extra level of care, they're having to travel outside Lincolnshire to get that, and so that will be referrals from places like PHC, and Ward 12 would say that this person's a bit beyond our ability to keep them safe and well. They'll benefit from a more secure and less stimulus environment and refer on to a PQ. So what we really want is, because it's a small number of really quite high, mostly vulnerable people, we want to be able to support those people in Lincolnshire in the future. But yeah, it's just differential between those two types of ward.
Thank you, Chris. I was just going to add as well that since we put in the initial psychiatric intensive care unit, we have developed and expanded additional community support. We have our mental health helplines now. We've got our we're investing in the voluntary sector in terms of men's talking groups as well across the whole of Lincolnshire. We've got crisis cafes, latest one's just opened in Skegness, which I'm absolutely delighted about because it's been a long time coming. We've got our mental health urgent assessment centre, psychiatric clinical decisions unit, and we're at the point now where we are using our external partners such as the university, such as the East Midlands Academic Health Science Network, to do the evaluations that we just don't have the skills necessarily in the NHS to do in terms of what has been the impact of putting these services on. And sometimes it could be a mixture of all of those things that are providing that early support and early intervention that prevents people getting poorlier along the way. But just to say as well, at Peter Hodgkinson Centre, we are opening our new wards, so we will be providing those. It's currently dormitory ward provision, and it's going to be ground floor, very therapeutic, single ensuite accommodation for our population, which again is what they deserve and what our staff deserve, the conditions that they deserve to be working in, which again will further enhance the therapeutic environment, and we look with interest in terms of what that might do for our average length of stay, for example. I hope that helps answer your question, Councillor.
Yes, thank you very much. And I just wondered more about the question about, again, male to female needs, if you see what I mean, the future requirements. I don't know, again, is that something that requires collaboration with academics, with universities? Or is that something that you can do yourselves, that sort of research?
If I just add in, and Chris or Andy might want to jump in, but we are talking about specialist end of treatment here, and we do work with our East Midlands mental health partners as well in Derbyshire, Leicestershire, Nottinghamshire, Northamptonshire, for example, on a sort of wider 5 million population footprint in terms of those really specialist mental health services. What does that look like on a wider population basis? What do the residents of Lincolnshire need, and what do the residents of East Midlands need as well? And it is very much coming from a what does the female pathway need to look like versus the male pathway, as Chris alluded to. Sometimes they definitely need different provision to meet their requirements. I don't know, Chris and Andy, if you want to come in more.
Yeah, just add on that modelling work is something we can do in the organisation. I think we can look at our trend over time and see what and predict on population increase and things, what we might need in the future on those things. I think because the trick here is what makes it challenging is because it's such small numbers, it is what we consider kind of standard variation in terms of demand. There will be times where there's low demand like now, and there'll be times where it's increased. And I suppose we've just got to make sure that we've got flexibility in our bed capacity to manage those peaks in demand, or we accept that we send people out of area at those points, which is not comfortable for any of us. So I think that's where we can look at flexible use of our beds. I think we just need to look at a different model in the future about how we can flex them around depending as to adapt to those changes in demand. But that just needs thinking through, but it is something we can do with our ICB colleagues here in the system.
Thank you.
Okay, thank you. I've got no other speakers indicated, so I've just got a couple of questions myself. And the first one is on page 37, the first bullet point. Can you please advise how far out of county these patients were placed? And has this displacement led to an extended treatment time, with the patients, in essence, having to retell their story or rebuild the trust with new clinical staff?
So further than we'd like, so some people had to go to Sussex. I think 1 or 2 people had to go down to a unit in there. Where we choose to place people is based on a couple of different factors. We've got a comprehensive bed management team that support those decisions and support people when they're placed out of area. That we are looking at trying to arrange a block purchase some beds with local providers or more local providers, but we want to make sure the quality of that provision is good. And first and foremost, we'd rather, with conversation with the patients and their families, place somebody in a high quality unit, and that might be further away than place somebody in a lesser quality unit closer to home. And so it's a balance between the two with a conversation with families. So we just make sure that the quality of the unit is effective. It's also based on bed availability at the point of time when that admission is required. And sometimes we have to place further afield, like the case in Sussex, because there's not a local bed available in our nearest patch. But as I say, we are still working with our neighbouring trusts to see if we can block purchase some beds that we can access as and when we need them. But clearly further than any of us would want. To try to support that and mitigate that, our bed management team are in active contact, visiting physically and virtually as required. They act as a member of the care team, joining multidisciplinary team meetings or ward rounds to talk about what's going on for the patients, and at the earliest and the most appropriate opportunity, they're transferred back into Lincolnshire or back into another setting, again in conjunction with the patient and their families. Sometimes it's better for the person to continue their stay with that team that they're placed with because they've developed those relationships and they've got a package of care. And so sometimes we'll let that run and let them finish their care journey there. In other circumstances, if they prefer and it's a real barrier, then we'll transfer them back. But it's very much individualised to the individual needs. Yeah, I hope that answers the question.
Okay, thank you. And my next 2 questions have somewhat been alluded to, but again on page 37, we've got the staff turnover rates listed. Can you please advise if exit interviews have taken place? And if so, what are the common reasons for leaving and what lessons have therefore been learned? And has this led to any changes being made?
Yes, so those turnover rates are across the adult inpatient services. So they pick up not just the PQ, but they pick up the starters and leavers across all our adult inpatient wards. Yes, leaving interviews, exit interviews are conducted for everybody who was prepared to have one, and there's a range of reasons why people leave. Some things are often for promotion. Often, majority of people leave because for other opportunities in the trust. We've got just a unique position over the last few years where there's so many new services coming online as part of the NHS's long-term plan to develop community services, that we've got some really new and interesting roles, often with higher pay bands that are attracting staff out of our inpatient units. Because of that, we're just trying to look at how we can enhance career opportunities in the inpatient ward. So we're looking at advanced clinical roles so that people can have a choice between managerial opportunities and clinical opportunities to develop their careers in an inpatient setting that's not traditionally been there for many opportunities for people. And we're also looking at remuneration. Is there ways to be able to support people? And for example, we introduced previously an environmental allowance on our PQ because we're recognising the intensity it's required to work in there. We're looking at options like that for our wards across the trust.
I think just to add to that as well, we've instigated stay conversations, so we're not talking to people when it's too late. So we offer to have conversations with staff so that we can understand if they are thinking about leaving, if there's any adjustments that we can make to encourage them to stay, which is proving quite popular. Thank you.
Okay, thank you. And my final question is, we've heard today how confident you are that you'll be able to re-recruit to the Hearts Home Centre. However, should you not be able to recruit or retain the sufficient staff, then what other options are on the table?
So as I kind of alluded to earlier around the female pathway conversation is concurrently while we're doing this recruitment work, we're looking at options around how we can use the resources we've got in different ways and come up with some options around that. So there are in the making some alternative plan B options, but I don't want to kind of put my nail my colours to the mast here and now. They need some working up to see if they're feasible or not. But ultimately, we've got choices about how we use our existing wards and staffing resource. And if for whatever reason we get to a point where it's just not doable in terms of recruiting the staff that we need in a reasonable time frame, then I think we'll be forced to look at what can we do with our existing resources to make sure that we can support this vulnerable group back in Lincolnshire. And there are ways we could do that, but we need some time to work that up. So we're suggesting over the next kind of 5 months, around the September time, I mentioned a kind of check-in point at September just to see where we've got with recruitment and retention. At the same time, working some options up around plan Bs for if that is not, if we've not got to the place we need in terms of recruitment, then there's some plan B options that we can all consider. So yeah, it's one of those things where at the moment it's full steam ahead. Let's do for every kind of recruitment. Let's get this unit back open. But in the background, let's have a look at some alternatives if it doesn't work out in the way that we intend.
And absolutely patient safety will be our number one priority. We have had some challenge in terms of, well, we can just fill all the shifts with agency, which we're not going to do that if it will compromise patient safety. So that's always going to be our number one priority in that in those conversations. Thank you.
Okay, thank you. I've got Councillor Lindworth just wanted to ask a quick supplementary question.
Thank you, Chairman. I just wanted to know, was it a secure unit? And we all know that it's really difficult to recruit mental health workers, and that also there's a lack of psychiatrists. But if I may, Chairman, with your indulgence, I looked back, the unit opened in 2017, and in 2020, the CQC report said it was outstanding, it was well led, and under safe and effective and caring and responsible, everything was good. So it would be great if this unit could come back into life and be utilised again. Thank you, Chairman.
Yeah, just respond to the particular question. Absolutely, you know, this is the right kind of service to have here in Lincolnshire, and I think we're all committed to that. So welcome the comments on that. In terms of type of unit, it's not a secure unit as such. It's not something like in the NHS term, secure unit means something where you've got forensic patients who've got a criminal history and are detained in a secure setting. It's not that type of unit, but it is secure in the sense that it's a controlled access and egress to the unit in terms of locked doors and controlled access. So it's secure in that sense, but not secure in the sense of it's not a forensic unit in that respect.
Thank you, Chairman.
Okay, thank you. In which case, I'm going to now move to the proposal, and I'd like to propose we note the report on the work to date to increase staffing across Lincolnshire's adult mental health wards and future projected timelines for reopening the Hearts Home Centre in Lincoln. I'd also like to propose that we request that Lincolnshire Partnership NHS Foundation Trust advises the committee of any further developments, including any changes to the proposed timelines, and we have a further update in September. Councillor Overton.
Thank you, that's really good. But this has actually been a really nice thing to hear, and I'm so pleased. I wonder if we couldn't change the note to support. You said note the progress. Could we support progress? Would that be possible? I think everybody has spoken in support. Thank you.
I'm happy to accept support the progress. So yeah, with that amendment, do I have a seconder to that, please? Thank you, Councillor Smith. All those in favour, in which case, that's supported unanimously. And I'd just like to thank our presenters for your time today. Thank you.
Thank you.
Yeah, thanks very much.
Thank you.
Thank you. Okay, in which case we've already taken agenda item 8. So that brings the meeting to a close. So thank you all for your attendance today. Thank you.